Yes,
We we can admit her.
हाँ हिरानंदनी में ना
Yeah, we can admit her. She can come there.
तो आज
Yeah.
Start. Good morning, all. After taking over the presidency of this association, this is the first CME in my tenure. At the outset, I thank the outgoing president, Dr. Vijaybai Khambate, for taking the association to the new heights, and I hope to emulate him. Today, our CME webinars are there on the first Sundays of every month. They are very popular, thanks to the untiring efforts of our clinical secretary, Dr. Anil Mehta, ably supported by Dr. Jawahar Mukhtar. Today, the Bombay Seaward Medical Association with Bombay Medical Union present jointly with Sir H.N. Reliance Foundation Hospital along with GPA, FFAPI, the Bombay D Ward Medical Association and Jain Doctors Federation, a webinar on mental health update. Today, the pressure on medical fraternity is colossal. bearing in mind what the entire world is facing following the outbreak of COVID-19. The country has gone through lockdown, social distancing, etc. The general public has been deprived of freedom of movement and activity. This has led to mental health issues, making today's CME more significant. Also, today we will be presenting a Lifetime Achievement Award on the behalf of Bombay Seaboard Medical Association to the renowned psychiatrist Dr. Asit Seth. I now hand over to Dr. Anil Mehta to conduct the further proceedings.
Thank you, President Dr. Kamlesh Shah. Welcome to the 8th webinar on mental health. We are also joined by our A World Medical Association. The WHO Constitution states health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. This is making mental health an integral and essential component of health. Mental health is much more than mere absence of mental disorder. We, the family physicians, the first point of contact to the society, have to deal with mental health disturbances day in and day out. Last 2 decades, especially this year 2020, has affected lives around us very badly and in totality. Let's take it up head on in this webinar. Bombay is blessed with best of the psychiatrists of the country. We have galaxy of masters with in-depth perception of mental health scenario around and who have greatly impacted the mental disorder treatment in our country. Above all, we are honored to have an opportunity to felicitate Dr. Asit Seth. Our first speaker, Dr. Harish Shetty, a multifaceted, multitasking, most sought after celebrity speaker. He has completed his MBBS, DPM, and MD from TN Medical College and St. GS Medical College, respectively. Dr. Harish Shetty has immense experience in school mental health and has conducted hundreds of workshops for students, teachers, heads of the educational institutions, and the non-teaching staff for more than 2 decades. His another passion he has immense experience in the field of disaster and mental health. He has worked with practically all the disasters struck to our country, including the cyclones and the earthquakes, and he has extensively counseled the victims and their family members and evaluated their rehabilitative processes. Dr. Harish Shetty has been training the judiciary also. So if you look at his profile, I think I would not come in between his talk and I will not, you will listen by yourself. May I present Dr. Harish Shetty to talk about a very, very nice subject that physician heal thyself. Dr. Harish Shetty.
Namaskar, everybody. So happy to be with you all. Thank you, Anil Bhai. Anil Bhai is my classmate at TNMC. Very bright, very smiling, very affable, very friendly. And even in the most difficult situation, he will crack a joke at Nair and he'll keep everybody in splits. I think a wonderful human being. Nice to be with you here. Thank you, Kamlesh Bhai, for taking on the reins again and wanting to emulate the earlier leader. Kaban is also the chip of the old block. Great psychiatrist, very calm, very comfortable. You can see him in his attire. He's cool today with the t-shirt. His father, Dr. Paresh Lakdawala, was my first undergraduate teacher, postgraduate teacher. Again, one person who never spoke bad about anybody and one person who had respect for everybody, younger to him and older to him. Happy to hear that Dr. Asit Seth is being felicitated with the Lifetime Achievement Award. Also happy to have Kersi Bhai, who's always dressed impeccably everywhere, anywhere. And he would be happily speaking about children. And Dr. Vihan Bhaiya, depression today. My dear friends, what I'm going to talk is based on my experience and also literature across the world. When somebody says healing thyself, the physician, in the COVID era, everything has changed. Everything has changed. Remember visiting the funeral after a doctor dies? IMA has a unique function of informing us when a doctor dies. We are very sad to inform that Dr. So and so passed away. His last rites will be at this place, and IMA will have a meeting at this place. Remember, my dear friends, you and I are going to be in that obituary very soon. At some point of time, Corona has really brought us into an existential questioning. After every funeral, we always say, "Ave su jhagdo karwanu bhai, આ બધું શું છે? આ બધું વિરાગ, આ બધું." And Corona has made us think about it day in and day out. Healing yourself is to remind yourself that you are perishable. You are a perishable item on this earth. And when you remind yourself and not get obsessed with it, your behavior changes. You become more kinder, more compassionate. You're not upset about your patient going to somebody else. You're not upset about somebody coming with a prescription of a different general practitioner to you. તમે તો આ આઈપા ગોલી, પણ હું હવે એ લેઉં છું. Nothing happens. Arun Shori has written his latest book, Preparing for Death. Asking ourselves existential questions keeps us calm, keeps us integrated with our heart and body, and keeps us alive. A lot of emotions are taken care of automatically because this vertical body will become horizontal one day and merge with the earth. That does not mean that we need to accelerate the entire process. We only need to be aware. And Corona has made us aware a small RNA protein is more powerful than the most powerful missile made by India, China, and the United States of America. So let us remind ourselves of the only truism on the earth, that is death. And life is an incurable disease. When we have this existential dilemmas, there are anxieties also. There are fears. अपना कुछ होएगा तो, अरे हुआ तो क्या, हेवन में और एक मीटिंग लेंगे, वहां मीटिंग करेंगे. Shahabuddin Rathod, the great poet from Gujarat, had said, "Taro pachi maro." And that truism helps us to understand and makes us feel better. The second most important thing is being aware of feelings. I meet a lot of doctors, physicians, general practitioners, and consultants. They tell me, the other day, a consultant said, if there's a death in the ICU, doctor, I'm not worried. I just numb myself and move on to the other. I told him, my dear friend, numbing yourself means you are blocking your feelings. And if you block your feelings, it's not going to rest. Unless feelings are reasonably resolved, it's going to explode somewhere. Numbing doesn't work. And he said, what should I do? I said, in the evening when you finish and remove your PPE apron or your coat, sit down with your colleague and say, यार लफड़ा हो गया यार, वो मर गया यार, मुझे पता ही नहीं था उसको वो ऐसा होने वाला था, क्या करे? And when you share your feelings and be vulnerable to somebody whom you love, when you hug your wife and say, my God, I had a bad day, darling, and she says, what happened? I missed the malaria, it was typhoid. I missed the fever, it was COVID. And that is awareness of feelings, awareness of most difficult emotions are very important for you to heal yourself. But there are some doctors say, Mane gusso kyare avti nathi. I don't get angry at all. We are all meditating. Buddha also got very angry. Jesus Christ was also very angry with the Jews. And those people who think that just because they talk in a very soft tone, they're compassionate. Soft tone does not mean compassion. Anger is also compassion. Awareness of feelings is very important. I still know so many doctors across the country, across the city, who refuse to cry. I don't cry. If I cry, I don't. If I'm not strong, my children will really collapse. If I'm not strong, my family, I'm the karta of the family. I asked him, oh, is that so? Then I told him, you will have to face a consequence. And he said, what? I said, if you're not able to accept sadness as normal, experience sadness as normal, you would not be able to really enjoy and feel the joy. You'll not be able to love as much as you have to, as you can. Which means what? Which means sadness is a positive emotion, depression is a negative state. It is a positive emotion. If a father, doctor father, cries at home because of any reason, because maybe he remembered his father, he remembered his grandfather, he remembered his wife, who's no more, nothing is going to happen to the children, even if they're small. They will say, "Hamara bapu normal father hai, ye Bhagwan nahi hai. He is not God. He is normal." Children want to see normal fathers and normal mothers, and if you do not have those feelings and experience it as it comes, what happens is you get a stoic face. You get a face which is hard. Even if the God has sculpted your face beautifully, it becomes stoic. It becomes like Amitabh Bachchan in Mohabbatein. Parampara, Pratishtha, or Anushasan is Gurukul ke teen niyam hai. So it's so important to be aware of feelings as it is, as it is. Anger is also a normal feeling, but anger in motion is irritability. And there are many people say, "Amne gusso to outreach nati." Who meditation karu chu, akho divas ma ek kalak meditation karu chu. Are Baba, if you block your anger, you'll have resentment. You'll have resentment. Resentment is like a cup of poison you drink and expect somebody else to die. If he comes in front of me, I feel extremely angry, but he is perfectly all right. And if you block your resentment, you'll have hostility. And if you block your hostility, you'll have rage and anger and then hate. What is very important for us is to be able to watch our feelings as it comes, as it goes, acknowledge the feeling, identify the feeling, experience the feeling, exhaust the feeling most of the times and feel good. Envy is also a very important feeling. Maneto, I got gold medal in MBBS, but his practice is bigger than mine. Are Bapu, practice to aiya. Who's going to come to you? Who's not going to come to you? You can strive and you work at your best and get as many patients as we can. But it is so difficult sometimes to accept somebody probably in illusionary terms doing better than you. It's an illusion. And to accept envy as normal is good. I still remember I applied for a job at a hospital, very young. I was very young after my MD. Four of us applied, all four friends. Those days we would tell each other, "Yahan job hai, chalo saath mein apply karenge." And there was a fifth fellow who refused to apply. I wrote his application form, but he got the job. He was not interested. And then I asked him, "How did you get?" He said, "I also don't know." And we were all envious. We went to a milk bar and had milk continuously. And at the end of the day, we realized that jobs come and go, but he's our friend. फोन उठा के हमने उससे बात किया, "भाई तूने क्या किया, क्या झोल क्या किया? What is it that you did that really helped you with the job?" He said, "I do not know." And that's what it is in life. There are 2 apples and 3 people. 2 only will get, 3rd will not get. So acknowledging your feeling, accepting your feeling. Sadness is a positive emotion. Crying is very healthy. There's a saying in UP, "Jo beh gaya wo pani hai, jo reh gaya wo zahar hai." Because the mind and the body talk to each other. If you do not give mind enough chance to express, the body is going to explode. And that, I think, is extremely important. As we look at all this, I still remember my days at KM Hospital. Those days, 20 years back, the dean of KM Hospital invited me and Dr. Arun Bal for conducting some workshops with the consultant. In one of the workshops, when Arun Bal and me, we said, "Why do not we smile at a patient?" An orthopedic surgeon got up and said, "No, Dr. Shetty, I don't agree with you." And I said, "Why?" And he said, "Dr. Shetty, if somebody comes with a collisus fracture, and if I smile at him, he will feel I'm making fun of him." I said, "No, you don't have to laugh. You don't have to crack a joke, smile." He said, "No, Dr. Shetty, if I make a grim face, he will feel that I'm serious about the entire situation." I asked him a question that time. I said, my dear friend, if a close relative of yours comes from a village and knocks your door at home that I have a fracture, I've come all the way to Bombay to see that you get operated. When you open the door, what would you say? You will greet him with a smile. And doctors forget that when they smile at patients, patient gets healed. But when the patient smiles back at you, you get healed. You get healed. Healing is always a two-way process. It's never a one-way process. But we are not robots. We can't smile all the time. I understand that. But what is very important is, I still remember Dr. Sagade from Hinduja Hospital. What a man, what a man. Even if there was a table death, the patient's close members would say, उसने सब कुछ कोशिश किया, फिर भी ऐसा हुआ, हमें कोई गम नहीं है. We are not upset at all because he did his best. And that is what is a doctor. And that's so important to feel that even in the municipal hospital with 100 patients, or even in a psychiatric practice with 50 patients, 100 patients, receiving the smile of the patient and acknowledgement is as healing as everybody else. I ask all family doctors across the country, why don't you write the names of 3 other family doctors on your prescription, practicing close to each other, and say, if I am not available for any reason, why don't you go try these 3 numbers? They are my friends. I have done that 20 years ago. In my prescription, there are name of 4 psychiatrists and 3 hospitals, and I'm going to increase it by 10 and say, for whatever reason you're not happy with me, for whatever reason you don't like me, please go to these doctors. So once one doctor objected and said, Harish, मैं तेरा assistant नहीं हूँ. मैंने बोला तू मेरा assistant नहीं है, तू मेरा boss है, इसके लिए तेरा नाम डाला. My dear doctors, कोई किसी का छीनने वाला नहीं है. And I'll tell you, if you write the names of other 4 GPs in your prescription practice who are practicing around, your life will be better. There'll be more practice for all the 4 doctors because the patient will understand that ये सब चारों साथ में काम कर रहे हैं. They're all working together. And that's a very beautiful concept to really heal yourself and not be the Amitabh Bachchan in an old movie. जहाँ मैं खड़ा होता हूँ वहाँ से line शुरू होती है. जरूरत क्या है यार? One Sunday emergency, one GP will see. Once a month emergency, you see. Other 3 weeks, somebody else will see. You'll have a good time with your wife and your children. And that, I think, is extremely important. Organizing your practice helps you heal your life. And that, I think, is important. Now, people say, I am Nastic. I said there is no Nastic. A Nastic is also an Astic, because you see that don't believe in God, that's also a form of worship. I don't believe in God. And I did a postgraduate course in comparative mythology to understand religions. I like the Chavyar of Jains. Eating early has been our habit in our villages before the sunset. It is scientific. Gayatri mantra for a Hindu is beautiful. Is beautiful. It really brings peace. Only not the words uttered from the lips, but the shlokas uttered from the heart and the brain. Namaz, Fajr and Zohar, at least 2 out of 5, makes you feel so relieved. And if you're a Jain, once in a while, Samak and Pratikaman also makes you feel completely. And if you really do not want to do anything of this sort, sit still in silence for 15 minutes a day. Mane Bhagwan Jota Nathi, sit still in silence for 15 minutes. Watch the thoughts, feelings going in your mind. And if you just watch it, it will slowly calm down as the ripples of the river calm down after you throw a stone. It is so important to understand that spirituality is as important as anything else. It's so important to understand that whatever religion you practice, whatever faith you have in, have a little nama. They say in Gujarati, namo tya game. I don't understand. I don't know the full real sense, but where you bend, you feel nice. It's important for us to understand this. You might feel this is not a psychiatrist talking, this is a preacher talking. No, there's very little difference between preaching and psychiatry. A lot of preaching has been found to be effective through double-blind crossover research. My dear friends, spirituality is also about rushing to the hospital when your close friend or your colleague is hospitalized. taking care of his patients without any other feeling, taking care of his finances when something goes wrong. I still remember a doctor fell ill and he had to go through angioplasty. And unfortunately, this doctor was very isolated. His wife came and said, "What to do, Dr. Shetty? This man is like this." But he has a WhatsApp group of doctors. I said, put that on in the group that he has to undergo angioplasty. He's very anxious and scared, and he needs help. And at least 8 to 10 doctors went and said, some offered money, some offered food in the house for the next 8 days, because sometimes you have no food. In India, anonymity is very big. We're all becoming isolated. Number of people attending funerals have gone down. And if that is part of your spirituality, then I think things work. A lot of research has gone into ways by which we heal. And there are 5 evidences which are extremely important. And one is, whether you like it or not, my dear friends, yoga has been accepted as scientifically useful for healing and maintaining the homeostasis between the mind and the body. I'm not saying it. The United States Navy announced a few days back on Twitter that their sailors are doing yoga in the battleships. Harvard said on the first days of the epidemic, that please do yoga to improve immunity. Enough evidences, double blind, enough brain research, but Indians will not do yoga. And Somvarti hu suru karish. Monday, 100%, Dr. Shetty, Monday. Why it's not a retirement benefit plan? It's supposed to be done by a 3-year-old child. The ancient philosophy is not philosophy. Patanjali was one of the biggest mental health professionals of the country. I am not saying it. Dr. N.S. Wahiya, the late Dr. N.S. Wahiya told me this. Patanjali and Bhagwan Buddha are the biggest mental health professionals. I'll tell you why. Yoga has gone to US Navy and everywhere. Americans are doing it left, right, and center. Vipassana has gone all over the world as mindfulness, and you have to pay for that. But for Vipassana, it is free. It is free. And what does it do? What does it do? Simple technique of breathing slowly brings the sympathetic and the parasympathetic nervous system into balance. The simple technique of yoga resets the hypothalamo pituitary adrenal axis and also prevents the steroid rain in the brain. Simple technique of breathing for 15 minutes. Avalam vilam chhod do. Even breathing slow and deep helps you to change your homeostasis and brings back balance between the mind and the body. And we will not respect it because it is ours. But let me tell you, US Navy. And if there's an intellectual among doctors, I would like to say that your hippocampus will improve, thereby improving your memory. Your amygdaloid body will calm down, which will bring down your anger. If you are a movement person, you'll calm down. Your prefrontal cortex will help you to improve your process of decision making. And the million, we know what doctors don't talk about. It's not fashionable. But that is a fact. Vipassana is mindfulness, which is used across the country by universities and students. And these are the 2 important methods of healing, which is very, very important. My dear friends, healing is understanding your mistakes in life. Yaar, kya karu yaar? Gadbad ho gaya. Accepting that things have gone wrong, accepting that you have not understood what's happening to the patient, accepting that you have erred. And then you'll find your heart slowly starts forgiving you. The next most important thing I would like to add is that as you practice, you'll find that some people have a glow on their face. One of them is Anil Mehta. Anil Mehta has a glow on his face. And people ask me, why is it that this one member in my family, my grandmother, my grandfather, or my uncle, there's something special about him. Everybody would like to go and speak to him. And the glow is because of the state of being of the person, the state of being. The state of being of the person is there's reasonable transparency between him and the world. The balance within and the balance outside is all right. He or she lives a life, I'm not saying an ascetic life, a saintly life, as much transparency as you can, because how you feel defines how you look. How you look does not define how you feel. If you feel good, your cheeks will shine, your eyes will glow, and your state of being is equanimous. Samanta, as Buddha said, and equanimity, as in English, is extremely important. That happens. We look at physical hygiene all the time, all the time. Get up in the morning, have a bath, say your stotra, your mantras, kurbani, and then start your day. Arre Baba, kachra jo aiya છે ને કાલનું કચરો છે ને કાલનું. That doctor screamed at me on the phone. I referred this patient to that consultant, but the consultant did not give me a call at all. And the patient is sitting on my head. I don't know what to tell the patient. Happens all the time, all the time. And then you're very upset. And on the next day, when you're having a bath, that goes around your mind, you don't know what the hell to do. And that really weighs on you. And if it adds continuously, just stopping your referral to that consultant does not help, because the consultant's behavior is inside your brain. Unless you resolve what happens here, it does not work. So pick up the phone and say, यार मैं तुझे 10 बार फोन किया, एक बार तो फोन करना मुझे. Patient मेरे दिमाग चाट रहा है यार, तुम क्या करते हो? What are you doing, sir? He'll say, and when there's an interaction, probably you learn why he did not call. So it's important to clear your head, even though the person is not in your touch. And what is stored in your consciousness is what hurts you the most. Building emotional wealth and emotional equity is extremely important. Emotional wealth would mean there's a lot of energy, but in the 21st century, it gets washed away by a lot of expectations, a lot of actions, a lot of activities. Building the emotional energy bank would mean, boss, 10 baje ghar jaunga. If I do not see that patient, somebody else will see him. If something happens to me, he will go to another doctor. But if something happens to me, my family will not find another husband, another wife, or another son. And that realization comes very late in practice. It comes very late in practice. Very few people have it, because these things are not taught in the colleges at all. આપણા કોલેજમાં શું પાલ્પેટ કરો, અહીંયા liver છે, right માં, left માં spleen છે, અહીંયા thyroid છે, ઉંગલી डालो, uterus છે. Arre Baba, that is not medicine alone. And what is very important is to understand that. My dear friends, new research says kindness changes the brain. A latest article, October 26, 2026, random acts of kindness. Random acts of kindness, simple acts of kindness. In one of our workshops, we shared that in your life, if you have enough, one kilo of rice and 1 kilo of vegetables, give it away once a month. Appreciating your colleague, random acts of kindness changes your brain. Evidence, okay. And in Harvard, there was a research where they showed Mother Teresa's film. Watching acts of kindness can also change your immunological system. It improves immunity. Karuna thi baddu thai bhai. And each one of us is born compassionate. Each one of us, but very few discover it in their lifetime. भूल जाते हैं. भागम भाग में आजू बाजू में कौन है दिखता नहीं यार. And I am not saying it, Americans are saying it, research evidence, कि just once in a while pick up the phone and say, मारू patient तारा पास गयो पण मने खबर નથી પડી, પણ તને ખબર પડી ભાઈ, તું fantastic काम करे. You have done a great job. Mind opens and the heart opens and you get automatically healed. But it's difficult to share a good word about others because there are 4 thoughts which stop you. And the first thought is, उसको लगेगा कि मैं उसको मस्का मार रहा हूं. मेरा जलन उसके सामने आ जाएगा. पॉइंट थर्ड, एंजाइटी होता है मेरे को ये बोलने के लिए. एंड द फोर्थ, શું ફાયદો છે બધું એ બધું તો બધું અમેરિકન સ્ટાઇલ છે, આપણા સ્ટાઇલ નથી. માય ડિયર ફ્રેન્ડ્સ, some people tell me अंदर से लगा तो बोलना चाहिए, नहीं लगा तो नहीं बोलना चाहिए. It should come from the soul. अरे बाबा, if it comes from the soul, arranged marriages would not have succeeded. તમને ખબર નથી કોણ છે બૈરી, તમારે એક વાર મળ્યા પછી, બે વાર મળ્યા પછી, 6 મહિના ફર્યા પછી you marry, then you start practicing I love you, start saying I love you, and that starts from the skin and enters the soul. It's not always from the soul to the skin. Dr. Vibhakar agrees with me, smiling gently. And that is why I'm saying, even if you do not feel like appreciation, start from outside. It starts from the vocal cords, goes to the brain, enters the heart, and it starts from the skin and goes into the heart. So I always say that compassion, each one of us is compassionate. Very few discover it in a lifetime. And that is something which really helps people heal. My dear friends, when you do all this, there'll always be a crisis in life. There is no person in this call, hundreds of doctors who have not faced a serious crisis in your own life. And Indians are basically feudal. Apda naam bhar javanu nati, our this should not go out. And I will not tell my sister-in-law, she's like Times of India, badda ne case. She'll tell everybody. I will not tell her, Baba, Su Baba. Every person has a crisis. There is, each one of us is struggling with something we do not know. It is so important for all of us to say, Mari, what lagi gai? I'm gripped. It is so important to accept that things have gone wrong. It's so important to kill shame and seek help. And those guys who are able to do that in this lifetime may merge with the Brahman, may not be born again. I mean, just a straight thought. And if you are able to understand that solitude is a good place to visit, but a bad place to stay, and put your hands up and say, 25 lakhs gone in Share Bazaar. My daughter has come back from the marriage. I don't know what to do. She's asking for a divorce. I feel very tense and extremely upset. My son, I've checked. I've given enough money to my son to settle on, but he has not done anything. My son, my grandson is troubling the entire family. એકલા એકલા રડવાનું નથી, ખુલીને કહેવાનું લફડા છે, મને હેલ્પ જોઈએ. And most of the doctors, let me tell you, don't seek help. Don't seek help. So it's important in crisis to really seek help. And that is something which I would say is extremely important. But the reasons why we do not express kindness, reasons why we do not really ask for help are something we need to explore too. Recently, there have been a lot of spate of violence across the country against doctors. It's important to arm yourself with tools to prevent that. It's important to say that our communication skills are better, but it's also important to understand that things are happening, even if you're good, even if you're the best doctor, even if you're very kind, even if you're very, still it happens, which means what? Which means that the neighboring doctors have to be all united. But he did not invite me for his opening. So what? He got beaten up. I'll rush to the police station. I'll rush to the hospital. And when you do that, what happens is you are opening your heart. He may be helped or not, but you're opening your heart and you get healed. My dear friends, somebody asked me the other day when I took a session with Corona Warriors. I take sessions with all the doctors who work in the ICU as well as in the wards. And they said, the hospital owner said, what is the best thing we can do? I said, the best thing we can do, 3 best things we can do. He said, best thing we can do is appreciation. What is the second best? Second best what we can do is appreciation. What is the third best? Third best what we can do is appreciation. And what does appreciation do? Appreciation opens your heart. You feel good. The other person feels good. And that is something which I think is very important. So from yoga to vipassana, from having 4 names of doctors in your own prescription pad, hu nahi to tame, mai nahi to tu, is what really helps. So my dear friends, as I slowly stop, in spite of doing all this, the mind can become hard like a stone. Nothing will interest you. Sion Dharavi and Switzerland appears the same. South Bombay and North Bombay appears the same. Nothing works. At that time, remember Amitabh Bachchan said, "Do boond khushi ki is oral polio." And Dr. Kirsi Chowda, Dr. Ashit Sheth, or Dr. Vyang Vai or Dr. Hari Shetty would say, "Ek goli khushi ki." Sertraline, ek khao, khush ho jao. So simple. So when you're really screwed here without reason, there is no reason. And doctors and Indians have this habit of, "Em came to you. Why did this happen? अरे भाई कारण पता नहीं. Science ने आज पण पता नहीं why Hari Shetty is depressed and why Chowda is not depressed. We do not know. And it's so important, my dear friends. Lastly, I would like to say, सभी अच्छा करते हुए भी फ्यूज उड़ सकता है. किसी का भी फ्यूज उड़ सकता है. And that's the time when you say, no yoga, no vipassana, no exercise, no job. Go to the friendly neighborhood psychologist and psychiatrist and see that your neurons will be receptive to all the good things which I said that you received. My dear friends, thank you, Anil Bhai, for inviting me. Thank you all for really being with me. And I would like to say three things. One about Dr. Ashit Sheth, one about Dr. Vihang Vaiya, and one about Kersi Bhai. Babaji is my very good friend. Babaji is now checking his slides. Aavse Baba, Baddu slide aavse. Ashit Sheth, sir, congratulations for this Lifetime Achievement Award. Dr. Ashit Sheth is my MD teacher. And what a day for a teacher to receive an award when one of his students is speaking before him. I think it's such a beautiful day for me, but though I'll have to leave early because I need to be on my show at 12 o'clock. Congratulations, sir. You deserve
Thank you.
a million Lifetime Achievement Awards and not one. What a day to be with Dr. Vihang Vaiya. I learned my psychiatry along with his jokes at R.N. Cooper Hospital. I learned all my jokes, not the naughty ones, only the vegetarian ones from Dr. Vihang Vaiya. Babaji and me, we are contemporaries and we almost work in the same field. We complement each other. With this, I would say, thank you for inviting me. I'm so grateful, Anil Bhai, Kavan, Paresh Bhai Lakadawala, and everybody here. And don't forget your Gayatri, don't forget your Fajr, Zohar, Asar, Maghrib, and Isha ka namaz. Don't forget your Naukar mantra. And don't forget your parents who are here, who are not there, for giving birth to you on this beautiful planet. This is all I can say about healing oneself. Thank you.
Thank you, Dr. Shetty. Great. I think the healing has started already. Dr. Kavan, please take over.
Thank you, sir. Thank you, Dr. Shetty, for a very enlightening talk. These are, sir, my take-home points from what he discussed. The first thing is, when we start, there was always a thing that angry young man. Today, I realize that angry young man is good. Second thing, what I took from him is right from kitne aadmi the. And when we talk about patient, it depends on naseeb apna apna. Third thing, वो ad आता है sir कि दाग अच्छे है. Today I realize कि दाग ही नहीं, रोना भी अच्छा है. Last thing, what I felt, I always thought that only I have competition only from Dr. Shetty and Dr. Bhaiya and Dr. Kersi Chowda. Ashit Sheth sir is too senior. But now I think I have a lot of serious competition from one Baba also, who markets his things very well. Of course, what he told in the last is that you love thy neighbors to heal yourself. As far as what he mentioned about Dr. Anil Mehta, sir, that glow can be without doubt and love also, sir. Lastly, before we conclude, what he said is goli khao or khud jaan jao. And on a more serious note, today I realize that we are perishable items. So we should tell our patients, पहले हमें इस्तेमाल करें, फिर विश्वास करें. That is what I conclude, sir, from your talk.
Thank you, Kavan. Thank you, everybody. I'll have to leave. Bye, sir. Bye. Take care. All the best. Bye, Dr. Vaya. Namaskar. Bye, sir.
Bye, sir.
Viyang, I think, is in a very, very pensive mode, very tense before his talk. Take care. Bye.
Kavan, you'll have to call Dr.
To continue
Kamlesh.
with the flow, may I call upon Dr. Kamlesh Shah, our newly installed president of Bombay Sea Ward Medical Association, to introduce Dr. Ashit Sheth, sir. Dr. Kamlesh Bhai.
Hello, medics. It gives me a great pleasure to present Lifetime Achievement Award to Dr. Ashit Seth. Dr. Ashit Seth needs no introduction. He is the senior most doctor in the field of psychiatry. His practice spans over 45 years. I am privileged to have known Dr. Seth since I stepped in the world of medicine. I have learned a lot from Dr. Seth, not only about psychiatry, but also his professional approach to the well-being of his patients. He deals with an invisible predator in the human mind. Dr. Seth has been a practicing psychiatrist for more than 45 years. He is also an honorary psychiatrist to the Bombay Hospital, Mumbai. In his retirement in 1994, he was an honorary professor of psychiatry at AM Hospital and GS Medical College. He taught undergraduate and postgraduate courses for more than 25 years. He has authored illustrated booklets on Alzheimer's disease and unexplained medical symptoms along with Dr. Vikram Patel. Since his retirement, sir is devoted to providing optimum mental health services. He has established a joint venture called as Unlimited Potentialities. Dr. Seth is also associated with Bombay Hospital and Advanced Multi-Speciality Hospital. Provides various facilities of psychological testing, pharmacotherapy, cognitive therapy, hypnotherapy, and others. Dr. Seth has authored more than 50 publications in national and international journals and written various chapters in medical textbooks. He has edited psychiatric section in the textbook of medicine published by API. He has received numerous awards. Dr. Vaidya Lectureship Award in 1993, Dr. K.T. Dolokia Lectureship Award in 2004, Dr. V.V. Jaikar Award in Oration in 2005, and Adesal Dalal Memorial Oration in 2013. We are very honored to be associated with you, sir, and it gives me an immense pleasure to present this Bombay Sea Ward Medical Association Lifetime Achievement Award to you. May I please call upon Dr. Vijay Khambati, our immediate past president, and Dr. Bharat Bhatt, president of GPA, to present the award to Dr. Ashit Seth. The award reads, the Bombay Sea Ward Medical Association Lifetime Achievement Award, presented to Dr. Ashit Seth for his outstanding contribution in the field of psychiatry. President Dr. Kamlesh Shah, Secretaries Dr. Kavan Lakdawala, Dr. Saurabh Shah, and Clinical Secretary Dr. Anil Mehta. Today, Sunday, 1st November 2020. So now, can I ask Dr. Seth, sir, to say a few words?
Can you see my face and everything is, yeah, everything is okay? Video and all that, yeah. Dear Dr. Kamlesh Shah, Dr. Anil Mehta, Dr. Advaryu, Kavan, Kersi, Dr. Bhatt, Dr. Mukhtiar, and other members who are in the audience. I don't know, despite having no achievement, I've been given this award. As Kavan mentioned, that when you reach seniority, some things are given to you as a parting gift. And this was, I think, is one of the good parting gift one can ever have. I remember that somewhere in late 60s, when I got engaged to my wife, Rekha, I had a severe attack of mumps with parotitis, orchitis, meningism. I had an excruciating headache, and I was persistently vomiting. At that moment, my father-in-law, Rekha's father, Dr. Sharad Desai, came to see me at Vileparle, where I was lying down. And he very aptly said that your WBC count is normal. You have no bacterial infection. Let's give you a course of corticosteroid. And I was given a massive dose of corticosteroid. I got out of meningism. Everything became all right. And today, of course, you know, in COVID also, a massive dose of cortisone is given to prevent complications. Well, that was not written in any textbook. I couldn't find the reference of giving corticosteroid for meningism in mumps anywhere. But his rationality was so clear, and it also helped me when I had a recurrent synovitis after Dr. Dholakia operated on me for my knee, where another course of cortisone helped me to control aseptic synovitis. After that, I had a persistent pain. I had a persistent pain in my left testicle, and this wouldn't go with any NSAID, nothing of the sort. No painkiller would help me. So my father-in-law had a very good friend, Dr. Ambalal Shah, a famous general practitioner, and he took me there to him and said, "Jara na gota sarka karne. Maro jamai che, paranmano che mari dikri ne. Ne gota ma gotala thaya che, jara sarku kar." He examined me and he said that this is very rare thing, that your persistent pain. There were a row of box files lying in his room. He opened one box file, searched out a reference, said, "Kali mixture mokli to leje." Next day, I received a bottle, old-time doctor giving mixture with the divisions and all that. It was written potassium iodide mixture. So he told me to take it twice a day. The pain disappeared. So I was impressed that even a family doctor who could maintain such a big references. And then as we were leaving, my father-in-law said, "Kashid, remember that every family has to have a family doctor. No doctor should treat themselves. Doctors are lousy patients. So let a general practitioner who has a maximum therapeutic experience, they are familiar with all the drugs and all the diseases. And the experience of there is different from a consultant. Consultant sees them in a cross-section wise, while a general practitioner sees them in the longitudinal." And that was a lesson which was engraved in my mind. And whenever possible, I always advise my patients to have a general practitioner. Incidentally, when I decided to take up psychiatry, In my family, everybody called me Gandano Doctor. He became famous. And then I realized that in medical profession, all other branches are considered to be better, superior, and more competent than a psychiatrist. If you see any patient with a physical symptom, he'll come with a big file with all the investigations, and they have been to all the doctors, ultimately ending up with a psychiatrist. Whether he has a panic attack, he has a headache, MRIs are done, CT scans are done, everything is done, ultimately getting fed up, they can end up with a psychiatrist. So it's no different. Even in past also, psychiatrists were considered shamans of medicine. That means everybody, sorry, my dog. Everybody would go to Bua, Bhagat, astrologers, tarot card readers. And then when the thing happens, they come to, there is a story that in KM hospital, there is a black magic performer in front of the hospital. And when he can't make people all right, he will refer them to Ward 19. So what is important here to realize that psychiatry has never achieved a respectable position. And my attempt right from beginning was the general practitioner has to be the first one, and most of the medical psychiatric problems should be treated. And I started orienting general practitioner from day one. Out of that came a book by Vikram Patel and me, Unexplained Medical Symptoms. It was well appreciated, and UN and WHO also, Vikram Patel, when he is a very, very famous psychiatrist working on a spreading, managing general practitioner. I think somebody must have heard about him. He's a brilliant boy, and he's doing a phenomenal work. So he took this book and showed it to WHO, and they wanted to publish in different languages, but didn't materialize. Fortunately, I entered into a place, AM Hospital, which had three excellent teachers, Dr. Vaya, Dr. Dungaji, and Dr. Jeste. And I had an excellent opportunity to be with him, and then Dr. Dungaji for 20 years. So this experience has inculcated the psychiatric discipline, and what I owe today is to them, and I really wish and hope that this remains with me and I can carry it forward. What they have taught is unique in every way, every discipline of life, what they have given me. And Dr. Dungaji particularly created interest in photography, which I have been pursuing very seriously. And also the literature, mystery books, music, all this has been inculcated by Dr. Dungaji. Before I end, Dr. Ambalal Shah's son, Dr. Nitin Shah, became our family friend and family physician. And it was a long association. And when my wife fell sick with pancreatic cancer, we missed him a lot. Today's general practice. Family doctor is becoming a entity which is not lasting. To search a good general practitioner is difficult. That devotion, that particular knowledge, you pick up anything and ask Nitin Bhai, he will tell you about a drug, about side effects and everything. Those caliber of GPs are becoming less. But I advise that if you want to live a stress-free life, have a good general practitioner in your life. Having a good general practitioner gives you a lot of relief, a lot of comfort, and a good consultant also, because they listen to consultants and consultants listen to them. So the communication with the consultant also works out very well. And I wish this particular practice survives and helps people to. Now today treating depression has become very simple, as Harish pointed out. It was in 1990 when Prozac was discovered, that is a Pentocid, and whole treatment of depression has become very simple. General practitioners writing Nexitos and other brands so comfortably. And I wish that depression can be treated by general practitioner and a lot of people would benefit. I thank all of you to give me this award. Whether I deserve it or not, I don't know, but I thank all of you in giving me this award. And I wish more people serve with treat their patients with antidepressant, and depression becomes a part of the treatment like common cold. Depression can be treated at general practitioner's level. Thank you very much, all of you.
Thank you, sir.
Congratulations, sir. Congratulations.
Thank you, sir. Well, sir, I had a personal agenda that you are conferred this award because I was told by my father that you and Dr. Vaiya, sir, motivated him to become a psychiatrist. He in turn beat me to become a shrink. So it is just, sir, my way of giving you back what I am suffering through. So thank you very much, sir. With this, we proceed further. May I call upon Dr. Jawahar Mukhtiar, sir, our one of the most dashing and dynamic committee members, to introduce Dr. Vihang Vaiya, sir.
Thank you, Kavan. I think you're going to take my job from now on because you're doing an absolutely fantastic job moderating this. Just to begin with, I was hearing Dr. Ashit Sheth talk about Dr. Nitin Shah so fondly. I just wanted to add, it was only about, I think, a year ago that, a little less than or a little more than a year ago, that Dr. Nitin Shah died. And just because I live and practice in the same geographical location that he used to live and practice in, I inherited a lot of his patients. And I haven't seen a single patient of Dr. Nitin Shah who hasn't come to me with tears in his eyes, missing his family physician. And I think that has left me in complete awe of Dr. Nitin Bhai. And I wish I had learned a few things from him. To manage this sort of respect in your patients is something which is unbelievable and beautiful in this day and age. And I agree with Dr. Ashit Sheth there completely. Unfortunately, good general practitioners seem to be going the way of the dinosaurs. I have been given the opportunity to introduce Dr. Vihang Vaiya today. Before I do that, I would just quote from Clive Staple Lewis. C.S. Lewis was a famous British author who's best known for his book, The Chronicles of Narnia, which has become a movie. And he writes in his 1940s book called The Problem of Pain. And he says, mental pain is less dramatic than physical pain, but it is more common and also more hard to bear. I think most general practitioners will vouch for that here. The frequent attempts to conceal mental pain increases the burden. It is easier to say my tooth is aching than to say that my heart is broken. And I think that's where we need some guidance from somebody like Dr. Vyang Vaya. Dr. Vaya is a professor emeritus of psychiatry at the R.N. Cooper Hospital, Mumbai. He is a founder, head of department of psychological medicine. He is an international distinguished fellow of the American Psychiatric Association. He has been a former professor of psychiatry at, say, GS Medical College, Mumbai, consultant psychiatrist at the Breach Candy and Lilavati hospitals, a trustee and consultant psychiatrist at Dr. H.D. Gandhi Hospital and the Dr. Bajikar Hospital. He is a member of the National Advisory Board of the Indian Association of Private Psychiatry, former international membership committee of the American Psychiatric Association, a life fellow of the Indian Psychiatric Society, a life fellow of the Association of Private Psychiatry. He's a former chairman and has served in many various capacities or in psychopharmacology section of the IPS, former chairman CME committees, the Indian Psychiatric Society, former chairman CME committee of the Indian Association of Private Psychiatry, member of the Positive Psychiatry section, World Psychiatric Association, founder, managing trustee and CEO of the Dr. N.S. Vaya Foundation. He's a past secretary of the Indian Psychiatric Society and has several publications in indexed medical journals, chapters in textbooks and monographs. I would now invite Dr. Vyang Vaya to take the stage. Thank you.
Thank you, Dr. Mukhtiar. And at the outset, let me just get my slides. Are the slides visible? Right.
Yes, sir.
So at the outset, I wish to thank Dr. Mukhtiar, Kamlesh Bhai, Dr. Anil Mehta, Kavan Lakdawala, all the office bearers and members of the C Ward Association, and of course, Sara for the behind the scene work that she has done. I'm not sure if Dr. Ashit Shet is still locked in, but I want to assure him that this is not a farewell or a goodbye award. This is just a halfway mark, I'm sure. At the outset, I also want to clarify that I have no conflict of interest in this presentation. This is by invitation, and some of the slides being presented today are pulled up from my past presentations. Let me begin with this famous or my favorite case of Mr. Srinivas. He was a high-ranking government officer who is now retired and he works for a private sector company. He is a known case of hypertension and diabetes which are controlled with treatment. It is now 3 years since the Supreme Court found him not guilty in a major corruption charge. He is now nominated to head a prestigious overseas assignment. But ever since the nomination was told to him, he has been repeatedly presenting with headache, diarrhea, palpitations, giddiness, body ache and impotence. And he seeks frequent leave on medical grounds. He says he has lost interest in work and he doesn't sleep too well, which he says is because of his worry about his health. He has consulted endless number of physicians. There are countless blood tests and imaging studies, and there is no medical illness that is detected in this gentleman. It is now the ministry that has asked his employers to either help him in his health issues and make sure that he is certified fit to take up this overseas assignment. Since this is a one-way communication, let me begin by pointing out that he is worried about his health. He is not worried about his illness. He doesn't say, I'm ill, get me well. He says, make me feel well. I'm worried about my health, not the illness. So a case like this, I would begin with first establishing a rapport. When we start questioning, we have to tell the patient that this is a medical examination and not a CBI inquiry. We would want to check out relevant details and the status of these three features: high blood pressure and blood sugar, loss of interest in job, and disturbed sleep. To begin with, I would tell the patient that these three are interconnected. And because they are interconnected, let's find out the cause-effect relationship of what came first, the stress, the blood sugar, or the blood pressure. I'd also like to know whether the loss of interest in job is because he can't remember well, because he cannot take quick decisions, or because there are too many negative memories and the baggage of past court cases that haunt him and take away his interest. I'd like to know more about his difficulty in sleep, whether he can't get sleep, or whether he wakes up repeatedly, or whether he has lost his appetite and libido. And I would ask him, point blank up front, I would ask him that when he can't sleep, does he feel life is worthless, or has he planned to end his life? Or does he get thoughts कि इससे तो मर जाएगा तो अच्छा है? This is a question I would put up front in a manner which is gentle, saying, do you find life worthless? And then the rest of it follows. All these symptoms become a matter of concern if they are present for most days and most time of the day for a minimum period of 2 weeks. Once this is established, I would help the patient to acknowledge, accept, and act on the disorder of depression. For a busy family practitioner, I do not want to use the word general practitioner because there is nothing general about the practice that you do. You all are multi-specialty clinicians who have no time like a psychiatrist would have or should have. So what would a busy private practitioner or a primary care physician do to establish diagnosis of depression? There's a 2-question test. Ask the person if he feels low or she feels low, depressed, or hopeless. It's more common in females. Or just yes or no. Or if the person has now lost interest in things that were habitually entertaining or encouraging, including physical intimacies, without inquiring about the partner. If the answer is yes to either of these, you have your patient of depression. If you want to be more particular, check. All of us get these thoughts sometime or the other in our life. All of us feel low down and depressed, and all of us at times lose interest. But these are fleeting things. If these symptoms persist on most days and most part of the day for a continuous period of 1 month or more, then we have our case of depression. A transient depressive feeling is not depressive disorder. If you want to be more particular, we can ask for appetite, confidence, thought of ending life, feeling of guilt or shame, difficulty in concentration, and disturbed sleep on most days and most part of the day for a minimum period of last 1 month continuously. Having done this, I would draw my patient's attention to a study done by the World Health Organization in 2004 with projection of what's going to happen in 2030. The WHO data suggests that unipolar depressive disorder will be the commonest disorder of mankind by the year 2030. Probably the pandemic of COVID has brought this up in 2020 itself. Interestingly, road accidents are much less since the onset of pandemic. In fact, the number of lives saved because no road accidents is more than the number of lives lost to COVID. And most hospitals say that the number of ischemic heart disease and cerebrovascular accidents have actually decreased during the COVID period. Whatever the reason, I don't know. It's also interesting to know that though we will have more COPD in spite of low respiratory infections, we will have more hearing loss of adult onset and refractory errors. And probably people will be so busy watching their mobile phones, computer screens, or the TV that there will be less physical intimacies and hence less chances or opportunities to get HIV and AIDS. And of course, we will become couch potatoes and more diabetes. Obstetricians and pediatricians are so good that we will have less obstetric and pediatric neonatal pathologies. And since we all drink water bottles rather than taps, we'll have less diarrhea. Take a look, not at just the 5, but at the first 10 commonest disorders of mankind. These are lifestyle related, meaning stress related disorders. Because when we say the stress related, it automatically means these are anxiety and depression related disorders. And remember, these are disorders. They are not diseases. There's a difference between a disorder and a disease. So what is the difference? When we say, I'm feeling well, or when your patient says, doctor, I'm feeling well, what the patient conveys that all the body systems are functioning at ease. Even if there has been a fracture or a heart attack or asthma or any other disorder, chronic disorder, at that point in time, feeling well means all body systems are functioning at ease. Figure of speech. The concept of wellness is equal to being at ease. And any obliteration of the sense of wellness means that the person is not at ease. In other words, the patient is ill at ease. And common English, this translates into being dis at ease or disease or illness. Largest number of patients who come to a primary care physician, anywhere between 30 to 60% of the patients who come to a family physician do not have a disease, but they are, all their blood reports are normal, all investigations are normal, but they are not in order. They have a disorder. And when we talk of anxiety and depression and stress, if it is not a disease, what is it? Dr. Nesse pointed this out in 2005. Is it a defect, a defense, or a dysregulation? Is it a defect like Parkinsonism? Is it a defense like cough, fever, and pain? Or is it dysregulation like diabetes or thyroid? Dr. Nesse made this excellent argument to say that anxiety and depression are actually body defenses. Then, what is a body defense? We have multiple body defenses. They guard against the evil. Like diarrhea is a defense against something bad that is eaten, or cough is against what we inhale, or fever when there are toxins, or fatigue when we are exhausted, or pain when we stretch ourselves too much. Anxiety is a defense against difficult tasks. Nobody is ever anxious about an energy consuming happy task. But even a minimal energy consuming difficult task produces anxiety. Likewise, depression is a defense against failure. It helps the person to introspect, evaluate, and negotiate stress. Well, if it is a defense, why treat it? Any defense can become disabling or can become a disease. For example, diarrhea with dehydration. One single loose stool we don't treat, but if there's dehydration, we'll treat. One cough we don't treat, but if there's collapse or consolidation, we treat. Likewise, hyperpyrexia, neurasthenia, or pain causing immobility have to be treated. When a person is so anxious that the person cannot perform active daily living, we have got to treat it. As Nesse says, depression is not a disease. The way we respond to depression makes it a disorder. It's good to be depressed in life because that's a stepping stone to success. We find ways of overcoming obstacles in life. Depression is not a disease. Depression is a disorder when it becomes impairing. When depression is associated with disability, thoughts of ending life, or memory difficulty, then we need to treat it. So what is stress? Stress is essential in life. Life without stress will be so complacent and meaningless. There is something called eustress or optimal stress. Think of our examination, our last qualifying examination. When the timetable got put up, we put in more effort to study and we started remembering things that we didn't even remember that we remembered. It's only when stress becomes a distress that it needs to be treated. And distress is manifest as anxiety, worry, restlessness, the same thing repeating, same thoughts repeating, irritability, fatigue, muscle tension, poor concentration, or dims or does, disorder of initiating and maintaining sleep, or disorder of excessive sleep. મારે પડી જ રહેવું છે, मी ફક્ત ઝોપું ના, મારે કાંઈ करायचं नाहीये, હું મને leave me alone, let me just lie down, I feel sleepy all the time. And remember that like stress induces distress, distress induces stress. So the patient gets into a self-perpetuating, reverberating cycle unless we break the distress cycle or distress symptoms. So, what is stress? Stress is any event that requires new learning or adapting. There can be a negative stress, there can also be a positive stress. Somebody winning a 5 crore in say KBC or lottery also is under stress. Anything that requires new learning or adapting is stress. And when a person is under stress, happy stress or a sad stress, it produces recurrent thoughts. The sad stress produces sadness, tension, worries, and apprehension. The person is so lost in thinking that the person loses sleep. That's a most frequent symptom. And depending upon the level of vulnerability, this is a rich decoction for depression. When we talk of vulnerability, we have the biopsychosocial model. Somebody called it the biopsychosocial model, meaning to say not a gender specific, but spouse or family specific variables that can be genetic or the Vietnam diet. That is any event, vascular immunity, alcohol, nutrition, anything that weakens the brain increases vulnerability to depression. Anything, either is genetic or acquired in any form of Vietnam diet, increases the vulnerability to stress and depression. And these will be triggered by psychological pressures. These will be triggered by psychosocial factors in real life. So what do? We first every single physician, including several psychiatrists, want to learn to differentiate anxiety from depression. One, it is simple. Two, it is not even necessary to differentiate. But at a primary care physician's level, somatic symptoms is the commonest presentation of anxiety. From head to toe, every single organ, including genitals and impotence, are not in order. And a primary care physician would then want to know whether this is real physical disease or whether this is anxiety and depression. The World Health Organization says that if a patient presents to you with pain or any disturbance affecting more than 3 systems, lasting more than 3 months, and not responding to standard line of treatment, should arouse a diagnosis of anxiety and depression. 3 systems, more than 3 months, not responding to standard treatment. No human being is otherwise a walking museum of disorders. So, what is anxiety? Anxiety is chinta, fikar, ghabrat, tanav, and tension. In a city like Bombay, tension is a status symbol. If you are not tense and if you are having good time, something is probably wrong with you. It's important for a city like Bombay to have this prestigious symptom of tension. And then depression is udas, nirash, lachar, bebas, और साहब मन में बहुत दुख है, मैं दुखी हूँ. That is depression. Anxiety and depression are 2 ends of a continuum. Person may be largely anxious or obsessive or phobic, or depression, major depression. Most patients have an equal amount of anxiety, depression. Some may be more anxious, less depressed, or less anxious and more depressed. In either case, 73% of the patients present with mixed symptoms of anxiety and depression in different proportions. And the impact is that all antidepressants remove or alleviate anxiety, and all anti-anxiety drugs have some amount of improvement of mood. Today, since 1990, between 1990 and 2000 was the decade of the brain, and a whole lot of research occurred on brain as the seat of mental illness. And without doubt, without any contradiction, we know that depression is a disorder of the brain. We also know that untreated depression causes shrinking of the hippocampus, and the duration of the quantum of shrinking of hippocampus is proportional to the duration of untreated depression. So we have to treat depression emphatically. Not just that, before we make a diagnosis of depression, we take a note of the symptoms. Not only emotional, physical, and behavioral, including death wish and suicidal ideas, we look at cognitive symptoms. All of you know better than I do that a patient of depression, we cannot distract the patient. When the patient is narrating out symptoms which you know have no physical basis, you can't take the patient onto any other topic. Patients become self-centered and disorder-centered. Doctor, એ તો બધું ખરું પણ મારી બીમારીનું શું? Then they have negative memories. એમ જ થાય. Every time when mother-in-law comes to visit me, I feel bad. Every time my neighbor goes away, I feel bad. Every time my boss starts yelling at somebody else, I feel bad. Negative memories come back as, you know, like a film. And there is hopelessness. Abhi kabhi acha hone wala hi nahi hai. Every year in monsoon, Bombay floods and my house gets flooded, and this is hopeless. I can't buy a new house. I'm destined to suffer. Or there is helplessness. आता मी काय करू? आता काय करायचं? हे असंच चालायचं. And there is either a sense of worthlessness or anger. Who's to blame for my miseries? The doctors become the easiest target. You gave me wrong medicines. That's why I'm not feeling well. Or there is deficit, confusion. Doctor, green pill is 2 pills 3 times a day, or the red pill is 1 tablet 4 times a day. You told me, but I forget. They keep asking the same question because they cannot make decision and they get confused. There are memory difficulties. I forget whether I had come to you yesterday or day before yesterday. Once is, doctor, you are asking me for fees, but didn't I pay you yesterday? And there is attention deficit. For a primary care physician, it is the severity of depression which also needs to be noted. So we might, for a diagnosis, one of these three, preferably 2 of these 3 symptoms must be present. But along with that, there has to be an impairment. There is presence of symptoms, no matter how intense. If the patient is not impaired, don't treat. Don't treat what ain't broke. Don't fix what is not broken. If the patient, irrespective of the amount of depression as you perceive it, has no impairment, don't treat. The patient has found his own way of dealing with life problems and does not need our treatment. For a patient to have diagnosis of mild depression, it should be just a few symptoms. For moderate depression, there should be clinically noticeable impairment. Mild depression usually has minimal or no impairment, but it's a severe depression with suicidal ideas that definitely requires to be treated. Now I'll make this easy to read for you. Look at the severity of the illness. This might be mild to moderate, severe without psychotic features, and severe with psychotic features. That is, I get these thoughts, strong thoughts, delusional thoughts. We won't go into the details, we don't have the time. But the treatment is drug therapy. Drug therapy, yes. More so for moderate than mild, but yes. No psychotic symptoms, drug therapy, yes. If there are psychotic symptoms along with antidepressants, we need to give an antipsychotic drug as well. Avoid giving a combination of an antidepressant with benzodiazepines. I'll come to it why. Some people say, can't I get well with psychotherapy? Doctor, I have referred the patient to you so that you can talk the patient out of the illness. For mild to moderate, there is some controversy. But please remember, a good common sense advice is not the same as psychotherapy. Psychotherapy is a structured therapy. Common sense, good counsel or advice based on my experience, that is good advice, that is not psychotherapy. And it may or may not work in moderate, it's likely to work in mild depressions. But for severe depressions, only psychotherapy is not a therapy of choice. Then what about combining drug therapy with psychotherapy? Yes, that's a good strategy. It works in patients who have real life problems or personal issues that they want to deal with. If there are no personal issues, it's probably what was in the past called endogenous depression, a depression without any reason, more often genetically mediated, more often like a bipolar depression or a recurrent depression disorder. Psychotherapy may or may not help. Reassurance will help, but psychotherapy may or may not help. But in patients of severe depression, focused psychotherapy or CBT helps. And in psychotic symptoms, along with antidepressants, we must add an antipsychotic drug which itself does not produce depression. So some of these newer drugs like aripiprazole or olanzapine or quetiapine work very well here. What about the ECTs? ECTs will work in moderate depression, not in mild depression. And they'll definitely work in severe depression, irrespective of the criticism against it. What's a good antidepressant drug? In the past, we had antidepressant drugs that would take at least 3 weeks to work. Patients want to get well by yesterday. They don't even want to wait till tomorrow. So we need drugs with fast actions. There are drugs like Walk Alert, for example, but that I would advise not to be used at the primary care level. They are the stimulating drugs, but they have their own problems. So it's best done in consultation or a very detailed evaluation of depression, and not make a person suddenly become active, still retaining the depressive thoughts, when the depressive thoughts and the activity might in fact make the patient prone to suicide. This antidepressant should be effective in all subtypes, should be safe in cardiac and renal diseases or other systemic disease, should have no drug-drug interaction, should be safe in pregnant and lactating mothers, should be safe on overdose. Overdose of tricyclic, the older antidepressants, was the second commonest cause of suicide. There is this whole science of cytochrome or isoenzyme related drug-drug interactions. We will not go into it today, but they should be easy to administer and should be cost effective. It's very rare to see a patient from a primary care physician or even some of the consultants who has not been given a benzodiazepine. In fact, there are combinations of an antidepressants with benzodiazepines, and that to my mind is terrible. Why is it terrible? It's effective, but it is not safe. When we give fixed drug combination of an antidepressant with a benzodiazepine, the benzodiazepine is actually an umbrella before the antidepressants work. But if you are giving a fixed dose, we cannot take away the umbrella, and the patient will continue to use benzodiazepines as long as the patient is on antidepressant, which could be anywhere from 2 years to lifelong. So even though benzodiazepines taken for more than 4 weeks or 4 months can cause more problems than benefits, patients will continue to take the drug. And what is the problem with benzodiazepine? One, it increases the risk of memory difficulty, and two, benzodiazepines relax the patient, relax the muscle tone, and that's why there is increased risk of fall. When the patient gets up from sleep in the middle of the night to go to the washroom, the muscle tone does not let the patient maintain posture, and that's why there is risk of fall. There are a whole lot of antidepressants. I'm not going into the details, but remember, drugs like fluoxetine, Ashit mentioned it, I think Harish also mentioned it, Prozac, it's a very good drug, but Prozac we should start low and go slow. In the first few days of Prozac or Flox, Prodap or Fludin or Fludac or Flunil, or there's 62 other brands of fluoxetine in the country. In the initial 5 days, there can be worsening of anxiety before the patient gets control. So you may use a benzodiazepine or simply reassure the patient. Sertraline and escitalopram have minimal drug-drug interaction. That's why they are safe. There's a huge dose range. Unlike the past, we now know that escitalopram more than sertraline, but all the SSRIs can produce stomach problems. They produce acidity. All new antidepressants are prone to producing stomach acidity. So be careful and be cautious. To make it easy, when you have a patient who has previous history of depression, repeat the previously effective drug. If the patient has hypomania or mania, use a mood stabilizer. That's a drug like lithium or sodium valproate or carbamazepine or lamotrigine or oxcarbazepine. These are the drugs that work as mood stabilizers. It's a very specialized topic. We don't have the time to go into the details. But no antidepressant should be given to a patient with history of mania without the cover of a mood stabilizer unless we want to risk a breakthrough hypomania. Drugs like quetiapine, olanzapine, and aripiprazole, they are antipsychotic drugs, but they also have very good mood stabilizing properties. When there is a history of epilepsy, please insist on the newer drugs. And so also when there is congestive glaucoma or prosthetic enlargement because of the atropine effect of the older drugs. If there are cardiac problems, no questions asked, newer drugs in consultation with a cardiologist preferably. For ever so long, depression with high risk suicide, older antidepressants are out because for ever so long we knew that they were the second common cause of suicidal attempts. When there are histaminic symptoms, gastric acidity or somatic symptoms of pain or anxiety and insomnia or depression associated with other physical illness, till about 5 years ago, we used to use smaller doses of tryptomer or prothiodan or Spectra. Now we have enough data to say that a drug like mirtazapine works very well, or duloxetine works they work very well in drugs in these conditions also. So, besides I'm going to take maybe 3-4 more minutes if you permit me, Dr. Saab. Besides the drug, forget the psychotherapy. It's important to talk to the patient. Please go beyond symptom control. Everybody talks to the patient. So what's the big deal? When we deal with a medical care, we want to talk of what is the disease that this person has. In mental health care, we look at what is the person that has this disorder. Ask the patient. Let me go back to the WHO. When the World Health Organization in 1946 defined health, not illness, health, it said it is complete social well-being and not mere physical, mental and social well-being, and not merely the absence of disease or infirmity. This was a definition which was coined in 46, which was signed in 46 and implemented in 1948. Between 1948 and 2020, the definition hasn't changed. The additional component of cultural and spiritual health is not a part of the original definition. It was included in the Alma Ata Declaration in 1978. So it's a part of health, but it is not the original definition of health. What's more, absence of disease or infirmity is only one part. We have got to go well beyond the absence of disease or infirmity. So what am I trying to tell you? The contemporary medicine contemporary psychiatry as we know today, changed after the Second World War. At the time of Second World War, the US military recruited a large number of psychiatrists whose only focus was misery and suffering should be minimized. All that the psychiatrists were required to do was to put the soldier back into combat as soon as possible. That was the only job. Get the guy back to fight the war. Sense of well-being did not matter to the US Army. Just get the bag, whether he feels good or bad, he's got to go and fight. So, the presumption was that when a good doctor makes the patient painless or alleviates the presenting symptoms, the patient is obliged to tell you that, doctor, I'm feeling well because I'm not sick anymore. This doesn't happen. When we remove the disease, the patient doesn't always feel well. A lot of patients will tell you, I'm better but not like I was before I fell sick. After 15 years of research, Seligman said that there is this PERMA model which is so easy for all of us to implement. Positive emotions. When patient comes to us, the patient thinks of everything negative in life. We'll give you a whole lot of list of things that make me feel worse, doctor. Help the patient to recall things that make me feel good. If you have this disease for 3 months, you could not have been morbid for 3 months. There must have been moments of happiness. Think of things that made you feel good in the midst of the disease process that you are suffering from. Think of positivity in life as much as you are preoccupied with negativity. It's important to remain engaged. Do things. Please continue to do things. During this COVID, I had countless webinars with countless corporate sectors where the only advice that I learned from the Harvard School of Psychiatry that taught me, keep yourself busy. If nothing else, do housework, sweeping, cleaning, vacuuming, washing. Keep yourself engaged in doing something. Idle mind is devil's workshop. In this COVID period, people say social distancing. That's a wrong word. The actual word is physical distancing and virtual socializing. Keep 6 feet of distance with the mask on, but have virtual socializing. Phone up people, have video consultation, have friends like the C Ward who will get you an audience to listen to you. Keep yourself busy. Have good relationship like C Ward Medical Association, for example. You have to have meaning in life. There should be something to live forward to. There should something, I should have an aim, not just say, okay, I'm alive because I'm not dead. That's not the way to live. I'm alive because this, that, and those are the things that I want to do. And of course, think of your achievements more than think of the failures. In depression, only the failure thoughts come to your mind. Think of your achievements. These are the skills that we can learn. Positive psychology has now become an international movement. Ladies and gentlemen, there are so many aspects of depression. Drug therapy, pharmacokinetics, cytochrome, drug interactions, cardiac safety, refractory errors, libido, constipation, weight gain, pregnancy, hospitalization. Of course, non-adherence is a big issue. All these are the topics that we can probably take up in the brainstorm. Sir, sorry to have taken 7 minutes more, but thank you very much. Thank you for being so patient. Thank you.
Thank you, sir, for a very lucid and excellent presentation. Sir, no problem. You can take still more time, but you have restricted to only 7 more minutes, sir. Well, sir, what I realized from your talk, I'll just summarize that the ideal mind is a devil's workshop. That is
Not
the
ideal,
first-
idle, not
Oh,
ideal.
sorry.
Idle mind is devil's workshop. Yeah.
Idle mind is devil's workshop.
Yeah.
Sir, what I learned today about depression is that there is a new model of depression which was never taught to us called the biopsychosocial model of depression. What I learned about anxiety and
Kawan,
depression.
please be careful. Don't say this to a patient, otherwise all the female patients will pounce on you. This is only a tongue-in-cheek. When I say biopsycho, I mean the associated, the spouse. All our wives will say that the husbands are terrible.
Thank you, sir.
It's the spouse.
Sir, the second thing I never knew about anxiety and depression is हम दोनों है अलग अलग, हम दोनों है जुदा जुदा, एक दूसरे से कभी कभी रहते हैं हम खफा खफा. Sir, you taught us today that psychiatrists are better at handling depression rather than their own mother-in-laws because क्योंकि सास भी कभी बहू थी. I just remember a dialogue that जब ये 2.5 किलो का अक्षर डिप्रेशन आदमी के ऊपर पड़ता है तो आदमी उठता नहीं उठ जाता है. And sir, lastly, thank you for your first slide that now I can go and say that अच्छे दिन really आने वाले हैं, maybe in 2030 as far as the psychiatrists are concerned. So sir, thank you very much for a very lucid and simplified presentation. As we go on further.
Just a sec, doctor, the lucid presentation is to come now. Dr. Kersey is going to do it and I've heard him do it.
Acha. Okay, sir. So I take back the lucid work and I stick to simplistic presentation, sir.
Yes.
Now may I call upon Dr. Vibhakar Bhai Advaryu, President of Bombay Medical Union, to introduce our own Dr. Kersey Chawda, sir. Dr. Advaryu, sir.
Unmute.
That's not happening. Maybe the aging has caught up with sir.
No, I think you'll have to remove the wire from the computer and do it again.
Hello.
Yeah.
Yes.
Dr. Kersi Chowda has been working as a psychiatrist for more than 35 years. He is a consultant at the PD Hinduja, National Hinduja Healthcare and the Sir H.N. Reliance Foundation hospitals. He is currently chairperson of the IPS task force dealing with college psychiatry. He is on the advisory board of the mental health panel of Project Mumbai 2, a BMC state government enterprise dealing with psychological problems of the MMR region. He has been a past president of the Bombay Psychiatry Society. He had been the chairperson or panelist of the various task forces of the Indian Psychiatry Society at its various meetings, notable among which are school psychiatry and counseling, ethical boundaries between client and doctor, dealing with the LGBTQ community, the acronym for lesbian, gay, bisexual, transgender, queer, and treatment of autism spectrum disorders, learning disabilities in children. Friend, Dr. Chowda will be speaking on common child psychiatric problems. Dr. Chowda, please.
Thank you, sir. It's always a pleasure to talk to family doctors. I do know that even when I had become a consultant, my parents actually wanted all their medical look to be looked at by my family doctor. She was a lovely lady. So I know, like what Dr. Ashit Sheth had said, it is so important for a family doctor to survive. And I would hope that you all do. I've always had problems with slides on Zoom, so I have given it to Sarah. Thank you so much, Sarah. I'm giving you a little more trouble. In today's talk, I'm going to attempt, it's going to be impossible to talk of all child psychiatric problems. I'm going to attempt to talk of 2 or 3 of the commonest ones that we see in clinical practice and hope that we can reach some conclusions as to what we can do about their treatment. Next slide, please. So Rajesh is a 12-year-old. He was brought in with complaints of restlessness and inability to focus for more than 15 minutes at a stretch, issues related to disturbing other students in class and regularly giving up incomplete work. His teachers complained regularly to the parents, and he had actually shifted school twice because his parents had felt that he was being singled out and that he was getting into trouble when it was not really when he should not have been. He seemed academically bright, was actually a very friendly kid, but he got into a lot of fights regularly. Next slide, please. Now, we all know we are talking about attention deficit disorder. And over here, let me just state, attention has nothing to do with intelligence. So often you'll have parents coming in and saying, but ye to ghano hushar chhe, why are you calling it attention deficit? Attention is different, intellectual ability is different. You have people who are extremely bright having attention deficit, and you have people who are extremely mentally slow having attention deficit disorder. We do say today the latest trends are that prevalence rates are 7 to 12%. 85% of diagnosed kids continue with this disorder in teenage, and a huge number now we know even continue in adulthood, especially if they haven't been treated when they're in children. It's much more in boys and girls, even though now girls are being diagnosed and treated much more often than before. Next, please. Why is it important to treat? A lot of people just say he'll outgrow it. No, he's not going to outgrow it. There is an increased risk for academic, social, functional, behavioral, and family dysfunction. Very often you have schisms in the family because mommy is trying to be, the disciplinarian, daddy tries to come in at night, and then he sees the sulking child and he says, what is this? I come home for just 2 hours. And why is this boy crying? So daddy becomes Santa Claus, mommy becomes the wicked witch. These are things that we see happening all the time. Very often kids with ADHD might have special educational needs just because they cannot focus enough. Almost always there will be more conflicts with parents, and it has been proved that they have increased rates of substance abuse, sexually transmitted diseases, and even vehicle accidents. Next, please. Today, we only talk of biology. You know, at one time we would say things about not being breastfed enough and cold mother and hard father or dominated father who was dominated by the mother, etc., etc. Today, we know there are a lot of biological changes. Amongst them, there is an overall reduction in brain size, specifically the caudate nucleus and the globus pallidus. The prefrontal cortex white matter is also reduced. There is a reduction in corpus callosum, cerebellar vermis, and the ventral striatum. All of these are the reward pathways. There is an abnormal frontostriatal connectivity and function. And you have poor attention, poor motor responses, poor inhibitory control, poor emotional control, all of which involve the ventromedial prefrontal cortex. Now, we must remember that probably in the years to come, it will become almost routine for us to do fMRIs and things like that. We'll actually be able to see all of this. Today, it is being done in our bigger centers. It's quite expensive, so nobody does it routinely, but we do know that all of this kind of thing happens. So today we know there are biological reasons for why we see this disordered behavior in children. And it is a must for all family doctors who deal with psychiatric illnesses to harp on them, to focus on them, so that it just doesn't become something esoteric. It doesn't become something hanging in the woods. It is actually something that we can see, we can feel, we can test. That is the important part of this. Next slide, please. We know there's a lot of genetics. There's impaired catecholamine signaling, there's slow PFC maturation, there are a whole bunch of networks involved. In children, we find hypoactivation in the frontoparietal and the ventral attention networks. And there's also hyperventilation in the default mode network. Now, this is maybe a little too complicated, but the bottom line is we now have electronic circuits in the brain. We know that they are there, and these circuits get affected when a child has attention deficit disorder. Next, please. What are the presentation styles? In preschool kids, you just see hyperactivity. So if a kid comes running into your clinic, throws things around, pushes things about, screams, shouts, and you want to just pick him up and throw him into the closest microwave, then you know that he's having hyperactivity. If there is inattention in school age, teachers know that there is a problem. If there is overt physical hyperactivity and impulsive behaviors, it was probably there less before puberty. After puberty, it does reduce, but then we see persistence that occurs as excessive talking, as recklessness, risk-taking, and very poor decision-making. If it has been untreated and persists into adulthood, and then later on into relationships and marriage, very often the spouse will come and say, he takes such poor decisions, and he keeps repeating them. He keeps taking the risk. What is wrong with him? Very often then it can be mixed up with other psychiatric diagnoses, which may also be comorbid, for example, bipolar disorders. Next, please. What are the diagnostic criteria? First of all, the most important is a comprehensive evaluation. Nothing can take the can take the place of that. It is imperative for all of us to be aware of the things that we have to look at, the things we have to ask, the history we have to take, what we are looking at in a child as he's running around or sitting. You ask him to do a particular task and you'll find he starts off beautifully and then his interest peters off very fast. Things like that are very, very obvious. The DSM-5 diagnostic criteria talk about 6 out of 9 inattentive issues, 6 out of 9 hyperactive impulsive criteria for at least 6 months with onset before age 7. And it has to be inappropriate to the developmental age, and it has to impair functional ability in at least 2 settings. This last thing is very important. Sometimes you find a kid who's badly behaved only at home and as good as gold outside. This becomes a situation where we have to think, is it actually attention deficit, or is it related to either the parenting style or the way the teacher is teaching or something like that? So the functional ability has to be impaired in at least 2 settings. This is an absolute must for diagnosis. We must also remember that at least in the West, there has been a lot of flack because kids who we might just consider to be mischievous have been diagnosed as having attention deficit disorder. There is an over-inclusiveness, and there are a huge number of kids who are getting stimulant therapy when maybe they would not have got it with the psychiatrists from India. We need to be aware of this. Next, please. There are other scales as well, including those with parent and teacher formats. So when I'm dealing with a child, and I suggest that when you deal with a child, get these formats, they're very easily available. Give it to the parent and tell the parent to tell the teacher that the child is being put on a medication. At the end of 1.5, 2 months, you want to reevaluate and see. The only way you will know if it actually makes a difference is for the teacher to do a baseline evaluation, and then after 2 months to do that revaluation again and see the change in the scores. This is something which is very, very important and unfortunately not used so often. Next, please. We have a whole bunch of developmental differential diagnosis, and very often these differentials actually are comorbid with the disorder. You will find developmental disabilities. Very often there is a learning disability associated with the attention deficit disorder, and each of them actually bites off the other, each of them worsens the other, and each of them has to be treated separately. Sometimes there is poor vision or hearing, you have depression, you have anxiety, there is a pediatric bipolar disorder, not very common, but we are diagnosing it more and more. And then you have the medical problems that all of us are aware of. Next, please. What do we do? The basic thing, as Dr. Vihang keeps saying over and over again, we have to educate, we have to educate, we have to educate. So you have to educate the parent, you have to educate the family, you have to educate the teachers. I mean, my usual thing is, supposing a kid is asthmatic and he suddenly gets an asthmatic attack. Would you shout at the kid? Would you beat him up? Would you say, get out of the class? No, you wouldn't. I mean, if you do, then you need my help. You would just say, come to take this asthmatic pump. Let us help you. Let us be supportive to you. Unfortunately, when a kid has attention deficit disorder, it's very difficult to be as nice and kind as sympathetic. So you normally shout and say, shut up, sit down there. Who do you think you are? Now, the kid is not doing it because he doesn't like your face. The kid is not doing it because he wants to be shouted at. The kid is doing it because there's a problem. We all know that being shouted at for something which is anyway a problem has the effect of actually aggravating that problem in the first place. So it is absolutely essential for us to educate and teach the teacher and even the principal sometimes that he's not doing it because he doesn't like the school or he doesn't like you. He's doing it because there's a problem. And we are dealing with the problem. There are behavioral interventions which are there, which we use. There are school interventions which are there, which we use. Next, please. And we do know that the addition of behavioral interventions to pharmacotherapy increases parent-teacher satisfaction with treatment and improves the child interpersonal relationships. So even though, by and large, the mainstay of all attention deficit hyperactive disorders is medical, is pharmacological, it is stupid for us not to have behavioral interventions as well, and not to make the parent and the teacher and the principal and the school part of the intervention process as well. It's nice for us to sit in our little chambers and say, take this medicine, you'll be fine. It'll be more effective for the kid if everybody becomes part of the treatment process. Next, please. Next. So what is the pharmacotherapy? The mainstay is stimulants, and the mainstay, the most effective, is methylphenidate. I remember 25 years ago, we used to import it. It used to cost some enormous amount, I think 50 or 60 rupees per tablet, which some very enterprising parents would get from a couple of pharmacies in Mumbai. Today, it is available locally. It makes it so much easier. The trade names that we use over here is Methodi, Advice, and Inspiral. We know that it increases the levels of dopamine and norepinephrine, and it's available as short-acting and long-acting preparations. Next, please. There are also there's also non-stimulant like atomoxetine, which selectively blocks reuptake at the noradrenergic neurons, and we normally give it. The dose is 0.5 milligram per kilogram per weight, up to 1.2 milligram per kilogram per weight. And over here, the trade name is, the usual trade names are Tomkid and Acceptor. Next, please. We use others. Clonidine is used especially in kids who have tics. It's used in aggression. It might be used in conduct disorders. Bupropion is another one which is used. It's actually an antidepressant, but there's a lot of evidence that shows that it has its effect in attention deficit disorder. Next, please. A lot of kids and a lot of parents get very affected by the thought of taking medication, and that's not surprising. I know that if I had a 7 or 8 or 9-year-old or 12-year-old kid, and I was told that he had attention deficit disorder and you have to be on, say, methylphenidate, And I went through Dr. Google, which is probably the worst thing in the world. And I saw that there's delayed sleep onset, there's usually decreased appetite and weight loss, very often headache, very often stomachache. There may be outbursts of emotion, and there may be nausea and sedation. I'd be a little wary of starting the medication. This is where good education and communication skills, which Dr. Vihang so beautifully has spoken about during his talk on depression, that is where it makes the difference. I have a huge number of kids who have been taking medication for 4 years, 5 years, 8 years. I think the longest that somebody has taken it so far has been about 15. And that parent actually came to me and said, I don't think I want to start the medication. Okay, I'm willing to give it a try, etc., etc. And after about 3 months, he came back and said, I should have done this 5 years ago. The bottom line is, people have to see the difference. Now, nobody in the least is suggesting that this is a panacea for everything, but everybody is saying you've got to try. Do not allow your own inhibitions. And do believe me, doctors also have a tremendous amount of inhibitions about medication. They're very gung-ho about prescribing it to other people, but if you have to prescribe it to your own family, it becomes very difficult. See the difference. We must realize that attention deficit disorder, which might initially manifest as only an academic or a social problem or a behavioral problem, then becomes something which is much, much more. People start avoiding him, people start shouting at him, the teachers are constantly screaming at him, and you'll end up having severe emotional issues just related to the fact that you don't, in a way, know how to behave. Next, please. There's this whole thing of, is there a growth issue because the kids often reduce their appetite. Now, data has been proved from 22 studies of stimulants, and it has demonstrated height deficits, suggesting lower growths than expected very initially in treatment. However, with time, the height seems to normalize. They also seem to have found deficits in weight, which seems to normalize in time. But overall, weight deficits are actually more significant than height loss. Next, please. Some people suggested that these effects were dose dependent. And there was this whole thing of, should we have drug-free holidays? I know when I started off and it had first come out into the market, when we really didn't know too much about it, we used to give drug-free holidays. We would say, don't give it on a Saturday, Sunday if the kid is not in school. If the kid is having a Christmas vacation or Diwali vacation, don't give it. If a politician dies and we have a holiday, don't give it, and things like that. Today, we know that it is no longer recommended. We say that you must give it all the time, which is why even in our COVID times, one of the biggest problems that we had faced is kids who were so well established on one of these medications. Suddenly, the distribution chains were stuck, and some of these were not supposed to be prescribed on a virtual prescription. It became very problematic for the parent and the child itself. Next, please. Atomoxetine has a few special issues. There is a black box warning against suicide. There is some amount of suicidal thoughts and behavior, a rare occurrence of liver toxicity. This thing about behavior, which is suicidal, there are lots of new studies coming out which are saying that it is not really true, and that the studies which were done in the past, which came out with these conclusions, were not done appropriately. But we still have to be a little careful about this. Probably the two main things that are main contraindications to giving either atomoxetine or methylphenidate is, number one, if there's a history of a heart problem in the child, you're not supposed to give it. And number two, tic disorders. Now, once again, the latest studies have said that tics do not actually get aggravated by the use of these medicines, but we are a little nervous. And in my 500 to 1,000 kids who I might have given these medicines to, I've had 2 kids who seem to have developed tics. Is that a major issue? I don't know. But if I see a kid who has a tic, or if I see a family history of tic, I don't give the medication. I prefer to be a little safe. Next, please. Many developmental disorders are associated with this. Give the next one, please. Next dose. We often see a problem in teenagers, because their adherence to stimulants is much less, not even 70%. And actually in teenage times, you probably need it more, because in addition to reducing the restlessness and the attentional issues, it also reduces impulse control behaviors, which is such an important aspect of teenage times. So it is necessary absolutely for us to make our teens partners in their own treatments. Next, please. People do use other tablets. Sometimes you add an antipsychotic, especially if there's a lot of aggression. You might add a quetiapine, you might add a risperidone. There people in the past, I know when I was part of the generation which used only the tricyclic antidepressants, and we did get some results. So people sometimes do use it when the stimulants don't seem to work. Often there is a use of mood stabilizers. If there's also something like a disruptive dysregulation disorder, then we do use antidepressants, which seem to be very, very effective. Next, please. There's this whole thing of diet control. About if there is diet control, will it make a difference? Should I restrict refined sugar? Should I avoid food with additives? And should I avoid refined flour? Yes, in the past, we used to talk about it very, very much. Today, it doesn't really seem to make much of a difference. But we do know anyway this is healthy if you restrict it. Whether it has an effect on attention deficit is a moot point. It won't do any harm to restrict it anyway. Next, please. For the very young child, most of our medications, the stimulants would start after the age of 6 or 7. Some people actually believe that it should start after the age of 9 and 10. So for the younger kid, occupational therapy is something that we know makes a tremendous amount of difference. In some of the schools in which I consult, in the preschool, undergoes some kind of occupational therapy, which actually takes the form of playing and joking around and fooling around. And that seems to just help them. Even borderline cases of attention deficit seem to reduce. There are studies which say that in the lower kids, it's in the lower age group, it is very, very effective. So it is worthwhile referring a child for occupational therapy below the age of about 6 or 7. It seems to make a lot of difference. Next, please. We move on from attention deficit disorder and come to something which is again becoming very, very commonplace and very commonplace in adolescence. It's also being found at younger and younger age groups. So Prajakta is a 17-year-old. She was brought to me for complaints of spending hours in the bathroom. She scrubbed herself, she scrubbed her clothes, she scrubbed sanitary ware over and over and over again. Can you go back to the previous one, please? Yeah. Go back to the previous one. Hello, first one. Yeah. She seemed to find it necessary to repeat the same thing about 8 to 9 times to be reassured that she has been properly understood. And I'm sure you've all faced up to this obsessive compulsive thing where the kid or the adult will actually tell you, doctor, are you sure? Doctor, repeat it to me again. I've had kids saying, please write it out what you're saying. And they go and laminate it and they've put it in their cupboard. So that whenever they feel this feeling of insecurity as to whether what they're experiencing is normal or not normal, they'd go into a situation where they'd read it and then they would decide that, okay, it's not so bad. She knew that she was behaving inappropriately, but just was so scared with the possibility of getting contaminated by dirt. And this is the important thing. 99% of people with OCD actually know, they have the insight that that their thoughts are silly. Maybe there's a very small percentage which believe that what they're actually saying is correct. But just about everybody knows that what they're thinking is inappropriate and they shouldn't be thinking it, but they can't seem to prevent it from happening. This is what we call the presence of insight. Next, please. Next. 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 Thank God I was not in charge of the slides. I'd be walking up the wall by now. Okay, so when you have OCDs, basically what happens is there's a presence of obsessions or compulsions or both, and they have to be extremely time consuming. We look at it as more than 1 hour a day, or they have to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So you have kids who can't complete their exams because the papers have to be aligned absolutely correctly. The pen has to be held in a particular way. You have people who are working who cannot finish the work, and then what should take just 5 hours takes about 10 because they have to rewrite and re-edit and re-edit and re-edit. You have people who, I've had a horrible case of a psychiatric social worker who just could not sleep on the bed because after she slept on the bed, she was so sure she had contaminated it that she had to wash the mattress, wash the bed, and give herself a head bath. So even though she had a fully functional room, she would sleep on the floor on a sheet so the sheet could be very easily washed. Sometimes we don't realize how difficult it is to be having an OCD. Next, please. It's again extremely common, but it's also extremely missed. Unless you're aware of it, you would miss it. The lifetime prevalence is supposed to be 2 to 3%. Men and women here are equally affected. And there is a 35% seen in first degree relatives. So if anybody in the family has it, there's a 35% chance that you will also have it. Next, please. What are obsessions? You know, sometimes people really don't know what an obsession is. First of all, it has to be recurrent. It has to be persistent. It's either a thought or an urge or an image. It is experienced in such a way that is intrusive and unwanted. I mean, you don't want it. You don't enjoy it, but it just keeps coming in and it causes anxiety. Because it causes anxiety, the person tries to ignore it. He tries to suppress it. And then he starts doing some kind of an action. And while he's doing the action, he finds that if I do this action in a particular way, which is what is called a ritualistic action, the anxiety becomes less. So that ritualistic action becomes more and more and more repetitive because that's the only way his anxiety can reduce. So for example, I think my hand is dirty. So I will wash it, but I will wash it in a particular way. First only the tips, then the palm, then the wrist, then I will go up to the elbows. And if I have skipped something, then I have to go through the whole ritual again because my hand is not clean enough. And this is what causes the problem. Next, please. Next. What is the cause? It's often chronic. It often lasts for very, very long. One of the most difficult things to treat, even though we don't pay it so much of attention. Sometimes the person has to be on medication almost lifelong. Pharmacotherapy here is much more effective than psychotherapy. But again, over here, CBT is known to be beneficial. Prognosis with therapy is fair, but sometimes it is intractable. Even with medication, sometimes you have people who say, okay, I'm doing better. I used to spend 10 hours in the bathroom. Now I spend only 1.5. For them, it's a big relief, but it is still something that is sad because it comes in the way of their life. Next, please. Over here, again, there's biology. So there's an imbalance between the excitatory loop and the inhibitory loop. And this imbalance leads to a brain lock in the caudate nucleus, what we call a hyperactivation between the OFC, the orbitofrontal cortex, and the thalamus. fMRIs, which I've spoken about before, spoke about increased activation in the brain ganglia. There is also low serotonin, includes glutamate, imbalanced dopamine. So all of these things are extremely biological and need to be made aware of. Next, please. The commonest scale we use, because now we like to use scale, especially to see whether or not the person is improving. And we have some treatments. For example, you have a gamma knife irradiation treatment where it is permitted as such only when there is a very high or a very severe scale, a severe amount in the Wybox scale. So this is a rating scale that is designed to rate the severity and the type of symptoms. Next, please. Next. There is an obsession checklist, which you can see. Next. Next. The scoring provides an idea of the severity of the disorder. Those with moderate to severe disorder often do not get control in spite of medication and behavior therapy. Today, with the newer medication, it does seem to be becoming much, much more in control. But even about 10 or 15 years ago, very often people had to continue to suffer. Next, please. What is the treatment? There is some amount of evidence that recognition of the problem, delaying the response of the problem, and something like a token economy seems to help. But the main treatment seems to be pharmacological. Next, please. What are the pharmacological agents used? Sertalin, fluoxetine, fluvoxamine, paroxetine. Clomipramine is the gold standard, and escitalopram. These are the ones which have tremendous evidence base behind them. For children, fluvoxamine is supposed to be used, and fluoxetine. By and large, it is not advocated below the age of 10. For adults, you can use any of these. My personal favorite are fluoxetine and clomipramine. Those two I have found very, very effective, but everybody has their own personal favorites, and they seem to be as good or as bad as the other. Next, please. People also use anxiolytics, for example, buspirone and clonazepam, and very often you would add a antipsychotic like a seroquine or a risperidone or an olanzapine, because these are the things which seem to also benefit, especially when there is agitation associated with OCDs. Next, please. Today, there is also psychosurgery that is being used. There are gamma knife procedures and deep brain stimulation. There are certain centers where you do have evidence that they seem to help, especially in the intractable cases. There are very, very strong and stringent criteria that are laid down before you can even think of any of these procedures. They have been laid down by in terms of international guidelines. Hinduja Hospital, to which I'm a consultant, the Mahim one, has become a center of excellence, and we've got very good results. I know that there are a lot of other hospitals which also do fantastic work in the same. Jaslok, I believe Breach Candy does it. I believe Saifi is doing it. Harkisan Das is in the process. So all of these are available, and we do see very, very good changes. Next, please. Okay, I don't think I'll have the time to go through anxiety disorders, so I'm not going to be doing it. However, what I'm going to talk about is a couple of other things. You can stop the slides because I don't think we'll have the time to go through more. One of the most important things that has been asked to me is how long does one person give medication? And I think the most important thing that we have to be aware of is that first episode of any kind of treatment, you have to give it for a period of at least 9 months to a year after stability. After that, you might want to try to taper it off, but the longer the person stays on that medication, the better. Dr. Vihang has already spoken about things like benzodiazepines, which you should not be giving for a very long time period. So yes, if initially you've added a benzodiazepine, get off it as soon as you can. But the SSRIs, the SNRIs, the antipsychotics, etc., should be for a long time period. We also know that they have protective influence on a lot of brain structures. So in COVID, for example, there are a lot of things which are beneficial, which are benefited by the use of antidepressants. We have to get over this fear of giving it for a long time period. The thing that I normally use is, if you're on an antihypertensive, you're going to take it for a long time period, maybe for the rest of your life. You're never going to say, can I get off it? Even if your pressure comes back to normal. Why then should you say, oh, I'm no longer feeling depressed, can I get off the medication? It's almost the same thing. Whether it's a hypothyroid case where you're taking L-Troxin, or it's a antihypertensive, or it's an anti-diabetic, no patient normally would tell the doctor, let me get off it, all my things seem normal, they take it for the rest of their lives. We have to start moving towards that regime, and doctors themselves are often very diffident about this. I know I had been very diffident about it. To tell somebody that you're going to stay on it for a very, very long time period is not easy. But if we know that relapses are common, and if we know that taking one silly tablet for 5 years, 10 years, 15 years gives you a terrific quality of life, especially for children who have their whole life waiting for them, then our own inhibitions and our own biases should not prevent what could land up being a terrific life and a terrific quality of life for our children. Thank you so much.
Thank you very much, sir, for a very fluid, I can use the word fluid now, sir, for you, and an excellent presentation, sir. What I took home from your message is that most of us doctors feel that their children have ADD, which is not normal. Second thing is COVID normalizes OCD, sir, because now we've been told to wash our hands again and again and again in a very particular way by none other than Shri Amitabh Bachchan ji. Third thing is, I had only heard of COVID-free holiday. Now I'm first time hearing something called drug-free holiday. And sir, for the others who don't know, that nowadays there is a trend of what we call, like chalti ka naam gaadi, there is a badti ka naam dadi. And of course, sir, before I conclude, I should bring a personal thing. This is for all the doctors as to how far they will go to get their children married. Well, this Parsi gentleman who gave a very excellent talk with his good books with the PMO sent his son away to Goa just before the lockdown and didn't bring him back for 6 months because he refused to get married. Now, this is to the level which the psychiatrists go. Well, thank you, sir. Now, there are a few questions which have cropped up. So first, I will invite Dr. Anil Mehta, sir, to post his queries. Dr. Anil Mehta, sir. Hello. Achha. Since till that time, sir, can I post one of my queries?
Go ahead, go ahead.
Yeah, sir, this has come from Dr. Moolchandani, who has posted to either of you as to how often the patients of OCD go into severe anxiety or depressive disorders. He's fine with any one of you answering it, sir.
All for
Yes,
Bihan.
Okay, all right, I'll take it. So OCD, anxiety is an integral part of the OCD syndrome. And obsession, panic, and phobia are the three anxiety syndromes that respond to antidepressant drug. What causes depression in OCD? There are two or three reasons why a person of OCD will feel depressed. One is the person finds the symptoms an obstacle to progress. Two, there is so much of time wasted or spent on rituals that there is no time left for something good to do. And three, this is inherently a disorder which is associated with depression. So OCD with depression responds to SSRI, not so much to a benzodiazepine. Pumping up benzodiazepine in this patient is actually a very wrong thing to do. And all that they need is a proper higher than doses for depression for treatment also. Antidepressants for OCD, the dose required is higher than the dose required for depression. I hope that answers the question. Dr. Kavan, sorry.
Yeah, if I may add, because I want to talk a little bit about children. Unfortunately, we see also a lot of kids who have OCD, and because they can't cope with the OCD and because people around them think that they are in a sense crazy and they tease them and they do a lot of things, we have them going into a depressive episode as well. And unfortunately, I've had kids who had suicide attempts being brought to me after the suicide attempt. And the only diagnosis that you could actually give them was it started off with an OCD. Sometimes we don't give OCD the kind of importance that it deserves. We consider it to be just one of those things, but believe me, it is not just one of them. Otherwise, what Dr. Vihang has said is absolutely appropriate, even in children.
And just one additional point, the youngest recorded patient of OCD was a 2-year-old child. Judith Rappaport recorded this, and the parents had gone to Judith Rappaport with video of the child's behavior, of repetitive behaviors, and any attempt to stop the repetition created anxiety. Where Judith reported the youngest OCD is a 2-year-old child, so it can occur at any age. And elderly become more ritualistic, that's another pathology, but then also they become OCD for sure.
The oldest was Shakespearean. Hamlet, where the lady kept washing her hands, washing her hands because she had killed somebody, and she felt that the blood of the person that she had killed was on her hands. So, you know, of course, it was Hamlet, Hamlet, your father's blood. When we, of course, make it Hamlet, Hamlet, your tera baap ka bhoot. But that's what it is. And if you're Parsi, you'll say omelette, omelette. Yeah. Kavan.
Yeah, Dr. Anil Mehta, sir, wanted to ask something.
So there were two questions. One, as general practitioner, every day we get requests from patient. They will call up, I am sending my driver, please give me the prescription of Restil or any sleeping tablet. And they keep on repeating their prescriptions. Now, we are also in a problem, like, we know the family, and then how to go about it? Should we ask them? Should we evaluate? Because years, I must have given for years the same prescription monthly, 2 monthly, we keep on giving. What do we do for that?
Vihang Saib, you're the boss here.
1988, the Royal College of Psychiatrists and the same year, American Psychiatric Association produced white paper on indiscreet use of benzodiazepines. When I got laptops and computers in my clinic, I started doing just one simple exercise. Anytime I prescribe a benzodiazepine, I add a note underneath saying that this drug can cause habit formation and sedation and increase the risk of fall. And I tell the patient that if you want to take it, but keep a record of how often you are using it. And every time you take a tablet, tell yourself, do I want to take the risk of a fall or habit formation? The number of benzodiazepines being consumed despite prescription went down by about 70%. I haven't kept an exact count, but 70%. So the question that Dr. Anil Bhai asked, this is a common problem. What I recommend that can be suggested is that talk to the patient and say, after taking these medicines for so long, I want to ask you, do you sometimes have difficulty in recalling things, especially the newer things? And invariably the patient would say yes. There is not one single patient who's taking benzodiazepines for 20 years who doesn't have subtle memory difficulties. And it is appropriate for you to say that, sir, your memory difficulty is very possibly, don't say definitely, but very possibly an effect of this drug that you are taking for ever so long. That's one thing I would tell them. Second thing I would tell them, there is no science on taking Restil for so long. So please realize that you are not taking Restil. Restil is taking you. So do you want to be a slave of the pill or the master of your mind? This is the exact question in these words that I put to the patient, that are you taking Restil or is Restil taking you? Restil is forcing you to ask me to do things which you know and I know should not be done. So are we going to be the slaves of Restil or the master of our mind? Many patients, Anil Bhai's patients who come from upper social strata, they are the ones who control the fate of number of employees and family members. You say, you can't stop yourself from being slave of a drug. Then do you still justify yourself wanting to control others? Bottom line is, we have to motivate the patient to go off the Restil and not force the patient to go off the Restil. If you force the patient to go off the Restil, if you don't give the prescription, instead of changing the drug, the patient will change the doctor. So we can't say no, but motivate the patient to say, I don't want it. It takes about 3 to 6 months of repeatedly saying this, when the patient will say, you have a point. Nowadays, large number of patients are internet medical graduates. So when you emphasize this, they'll go onto the internet, find out that what they are doing wrong, and they'll probably ask you for an help.
Excellent answer, Vihang. Excellent.
Sir, one more question for Dr. Chawda.
Haji.
Sir, what do you think that if the parents are reluctant in the beginning to take any psychiatric help, so what is the role of the school counselor? And if there can be a complete school teacher, the school counselor,
Yes.
the psychiatrist, and the general practitioner and the parents, if we make a complete circle somehow, then probably the child will be looked after well in the class, well in the school, well at home, and they would be more ready to do. So is there any methodology people
Yes,
are
sir.
doing it?
Yes,
So
sir. Sir, they do it
Please,
in they do it in parts. I mean, I work, let me let you into a small thing. When I had first finished my postgrad, then I got into a situation where I said the only way I can really learn enough about kids is to actually work in schools. So I had become a school counselor in about 7 to 10 schools, dealing with normal kids, special kids, spastics, special education, etc., etc. That's the only way I learned, because everything we learn in textbooks and a little bit with our patients, but you actually see them day in and day out and you see the change. I work a lot with the school counselor, and fortunately now school counselors have become fairly commonplace. Some schools are extremely open, some are not, we do the best that we can. You cannot change everybody. And finally, you decide that this far and no further. So I work a lot with school counselors. I work a lot with family doctors. Dr. Bhatt, I don't think he's there right now. We have collaborated on quite a few cases. And if the family doctor, very often, in fact, when I'm giving medication, the patient will say, I have to check this out with my family doctor. Would you mind if he calls you? And I say, please tell him to call me. Please tell him to WhatsApp me. I will give him a time and we can discuss the case. Because I know my parents, when I would say, Mom, take this. And she would say, no, first check it out with my family doctor. And I'd get angry with her. But I knew what it meant. The amount of trust that patients have with you is phenomenal. So we must do things together. Principals and schools, some principals and some schools are terrific. They go out of their way to be helpful. And some principals and some schools are so horrendous that you want to set a bomb in their premises. So it works. In some cases, it doesn't work in some cases. But Anil Saib, what you're saying is fantastic. I have been doing it. I know a lot of my colleagues who deal with children are doing it. We need to do much, much more of it. And thank you for reminding me about it, because maybe I haven't been as proactive as I could have been, especially with the GPs. Vihang Saib.
Kershi has a huge experience. My experience is minuscule compared to his. But I would approach Anil Bhai's question from 2 points of view. Counseling to treat the disorder and counseling to help the parents to cope or adapt to the situation. Counseling will help the parents to develop coping strategies. Counseling will not treat the disease. So you help the patients to cope with the disorder and also help the patient to accept doctor's advice. Another question that you raise is, we don't want to take medicines. Now, Anil Bhai, I am a little more assertive to the extent of people finding me aggressive in my approach. But I tell my patients, I hear them out. When they start repeating, I tell them not to repeat, but to make notes. And I actually make notes when a patient's telling me the sentence. So I read out the points that they have already told me. And then I point blank ask them one question. Do you want to follow your intuition? Do you want to follow the neighbor's advice? Or do you want a science? Do you want to follow what science says? Do you want to follow what your relatives and family says? Or do you want to follow your intuition? Childhood psychiatric disorders, particularly learning disorders, everybody thinks is a disorder which should occur in my neighbor's child and not my child. Well, that's a good thought, or not such a good thought. But the fact of the matter is that we have to accept that our child needs help, that there is science in how to help, and let us follow science. Following intuition, following neighbor's advice is a different story. Third thing, counseling. Good advice, sharing experience is different from psychoeducation. Educating the parents about the pathology and the science behind the pathology are 3 different things. Fourth thing, please remember that non-drug therapies are as effective as drug therapies in management of depression, and remedial training for a child with specific learning disorder is also just as effective than pushing in drugs. Why? Because remedial training changes the circuits in the brain. The recent data suggests that antidepressants also change the circuits in the brain. So we have got to opt for changing circuits in the brain. And if I may be permitted 1 more minute by Dr. Kavan, there was a research from a primary care physician in Boston who observed that every patient of anxiety and depression has a bad stomach. So he said, instead of controlling the stomach with antacids and anti-anxiety drugs, why not first control the stomach and see its effect on the brain? So he gave probiotics with at least 3 strains of lactobacillus to his patients of anxiety. He did a controlled study on women. It is a small sample. This is a primary care physician in Boston. and he did functional MRI pre and after probiotics given to patients of anxiety and depression. And he elicited that probiotics also change the circuits in the brain. So, giving probiotic lactobacillus to our patients of anxiety and depression works. In terms of Indian dietetics, probiotics with 3 strains of lactobacillus is the same as lassi or chas. Chas or lassi made out of cultured curds, not the dairy curds. But you can't have 5 liters of lassi or 5 liters of chas per day. And hence, the probiotic as an add-on to antidepressants for management of anxiety and depression is strongly recommended, and there is undeniable science behind this. Thank you.
Sir, a last question that has come from Dr. Asha Ben, that many times parents feel guilty when their children are given any psychological diagnosis. So what a family physician can do to counteract that, sir?
This is expected. And especially in Indian culture, where the parents hold themselves responsible for the child's well-being, this will happen. But this also happens worldwide. So the first reaction is never say no, say yes, but. So tell the patient that yes, of course, you are feeling guilty. And you are feeling sad, and you are finding yourself, you are holding yourself responsible for your child's misery. I agree with you. Now, the moment we say I agree with you, you take away that fight. It is not parents versus the doctor. It's parents and the doctor versus the wrong emotion. So we have to take the parents on our side by not saying you are wrong. Say you are right. But say that let us look at it differently. Whenever you did whatever did to your child, which you now feel guilty about, did you do it because of your own hidden agenda, or you did what you thought was the best thing for the child at that point in time? Your intentions for doing whatever that you did to the child or whatever advice you gave to the child at that point in time was what you thought was in the child's best interest. As it happens, in retrospect, we think it is a wrong advice, but then that is something which is inevitable. Karmanyavadhikaraste, ma phaleshu kadachana. You did your karma, you did your good karma by giving the child an advice which you thought was the best. Unfortunate that it didn't work out well. Karmanyavadhikaraste, you did your best without any hidden agenda or personal gain. It's unfortunate that it worked out differently. That's one. Two, I also would like to tell the parents that though both of you are wonderful, there is probably some genetic problem or some as yet not well understood genetic issue, probably a soft genetic issue which made your child vulnerable. I tell my parents categorically that genes do not transmit mental illness. Genes transmit vulnerability to mental illness. If there is one patient, one parent who's depressed or schizophrenia, all children do not develop depression or schizophrenia. But their threshold for developing depression and schizophrenia is lower than average. So don't hold yourself guilty. If I tell the parents, if I tell you, yes, this is genetic, can you go back and change your child's parenting or parentage? You can't. So let us not involve ourselves in futile mental masturbation. Please, we think not, excuses and explanations don't matter. Action matters. So let's act, and let's act positively. And if you want to act positively, you have to get these thoughts off your mind. The metaphor I gave them is that when you want to your car to drive well, you have to release the handbrake. If you keep the handbrakes on, your car won't run. So you have to give up your guilt and sense of some kind of a criminality by releasing the handbrake so that you can help your child optimally. Thank you. That is the end of my sermon.
Okay, Anil bhai, I want to just add because the last two, if you don't mind, Kavan, I'll just take 3 minutes.
No, sir, you can.
Thank you.
We are very considerate to Parsis.
Extinct species. Okay. So Anil bhai, you were asking about how do you tell parents, etc., etc. One of the most important ways that I have found over these years is by and large, most of us are clinically quite good. So if I have diagnosed a kid with something, what I tell the parents is, yes, you are a little nervous about starting medication. Can you give me 2 months of your child's life? In these 2 months, let us try the medication again. And especially when you're using a stimulant for attention deficit disorder, it is very rare that you do not see a change. So you tell them, I don't know how long I've got to give it. I don't even know if it is going to work, but I do know that it has made a difference in hundreds and hundreds of kids. And I know that parents have been very happy with it. Given all the circumstances, I think it's very correct that we should try it on your kid. Let us try it for a period of about 2 months. You come back to me after that. If it has worked, we'll see what to do. And if it has not worked, we'll see what you have to do. I would say more than 80% come back and say it has worked. We want to continue it. So it is not so difficult to get a kid to continue, to get a parent to continue giving medication to a child. And the second point, which Dr. Vihang so eloquently said in terms of guilt, one of the things I tell them is, yes, it is a pity this has happened. You did what you had to do at that time. Like he says, none of us are God. We did not know ahead of time that this would happen. And let me tell you that if you had come to me at that time, I would have probably given you the same advice. So what you did, and lots of, unfortunately also very often parents come up to us and say, that doctor gave this, was it the right medication? And of course it was the right medication. At that time, it was the right medicine that the doctor gave. He didn't know it would land up having a problem. He did what was best according to his level of understanding at that time. And I think that is something that we all have to also do. We have to support each other and not talk about, oh my God, how could the doctor have done that? That is so wrong, which sometimes we still land up doing. So my regular advice to every doctor fraternity who I talk about is, given the amount of legalities that we are now seeing, please let us also support each other, and at least to the patient who comes to us, never ever say, oh my God, what is this medication? Maybe sometimes some other doctor will say that about your prescriptions as well. So let's not do that.
Thank you.
Thank you. Kaval.
Sir, just there are a lot of questions, but Sarah has called up to say that she has a meeting with her fiance at 1:45. So she has told absolutely to cut short our discussion. But before we end, I have been given the task of thanking all of you. So, sir, first and foremost, I would like to thank all the associations which, along with our Bombay Sea Ward Medical Association and Bombay Medical Union, have bonded together to have this regular webinars which we are having on first Sunday of every month, especially the A Ward Medical Association, D Ward Medical Association, Jain Doctors Federation, General Practitioners Association, and of course, Sir H.N. Reliance Foundation Hospital. Sir, I would just summarize that we had a very entertaining CME this time with the great opening batsman Dr. Shetty, which was followed by Lifetime Achievement Award bestowed to Dr. Ashit Sheth sir. Then we had a solid middle order batsman in form of Dr. Vihang Bhaiya sir. And in the end, last but not the least, Tod-fod in the death overs by Dr. Chawda sir. It was very well coordinated by our coach and mentor, Dr. Anil Mehta sir, and of course our backroom staff, Sarah Ben and Manoj Bhai. Lastly, I should always thank the audience. They are making us what we are today. And sir, to conclude in Gujarati, what we say that if I have forgotten to thank someone, I would say tel piwa jao, because it's time to go for lunch. So thank you very much, sir, from my side. Sir.
Thank you. Cheers.
Sir.
Bye.
Bye, sir.
Thank you. Thank you for the wonderful time.
Thank you, sir.
Great fun.
Bye-bye.
Great fun. Bye.
Sir.